Good morning, everyone. The public meeting of November 6th. Sorry, I'm just putting my mic. Apologies, hopefully everyone can hear me. Colleagues, good morning. I'm very welcome to the Board of Directors meeting for the 6th. May I welcome our colleagues and members of the public joining online, and also Rachel Jones, who is non-executive director, who can't come to this morning physically, but she will be joining us online. So welcome to everyone. We begin this morning, first of all, actually with a reminder of why we're all here, why we do public service, why we care, appreciate and inspire, not just our activities and our community, but also everyone who's in this space of the NHS. A really wonderful illustration of that is the patient story. This morning, I'm really pleased we're going to actually get care. Sometimes we forget about our carers, but do you know, 1 in 3 of us at any time in our life will become a carer. We don't really plan for it, but when we encounter it, it can be very impactful. So over to you, Heather, to introduce the carer story.
Thank you, Chair. So this is a carer of someone who was a resident or stayed at Butler Green. Oh, I'm so sorry. Thank you, Chair. I will start again. This is a story from a carer of someone who was cared for at Butler Green Enhanced Intermediate Care Unit in Oldham. It talks to person-centred care, and in the words of the carers, they felt that colleagues did not give up on their loved one, but that really speaks to the strength-based approach that was used in this case. So I will hand you over to the.
He's registered blind, actually, Rodney, and he's got really, really bad hearing. So with all that in mind, it's not a straightforward care plan, and it's not been a straightforward journey. Rodney was took very, very poorly last year. Started to lose weight, considerable weight. Unfortunately, I went to Rodney's with his Sunday lunch, and he was very, very poorly in bed. So we rang an ambulance immediately, and that's when Rodney's journey started. Unfortunately, Rodney, he was in Oldham Hospital for about 6 months. That was very, very challenging. The experience wasn't brilliant at all. Matter of fact, in hospital, he came close to death a couple of times, and he progressed in losing weight and become very, very poorly. We had to find a better solution for Rodney, having either to have Rodney tested for what we thought would cause cancer. He was tested and unfortunately tested positive. In between times as well, Rodney was diagnosed with a muscle wasting disorder. We kind of hit a crossroads with his care, not knowing really where to go. Lots of sleepless nights. We were, after a long period of time in Oldham Hospital, we were asked whether it would be a possibility if Rodney could go into a place called Butler Green. Obviously, with the experience I had at Royal Oldham, I was very, very reluctant for Rodney to go anywhere else, but it was not an option really. And when Butler Green came up, I've got to tell you, I did ring Butler Green, ask what the facility was, etc, etc. I rang the ward, and I was advised that it wasn't like an old folks home, it's a rehabilitation centre where Rodney hopefully would be able to progress in a positive way. Having had the transfer to Butler Green, I was really nervous and, I've got to say, full of anxiety. On arrival, it was a really, real personal greeting that we got. They showed us his room, really warm welcome, I've got to say. The sister came in, introduced herself, and to me, myself and Rodney, and obviously my husband Nick, and basically it felt like a warm hug. That's all I can say. It didn't feel like you were going into a hospital. It didn't feel like I was going to be leaving him every evening panicking whether he'd be all right till morning, which was absolutely how I felt about Oldham Hospital. Sister in charge came in and introduced herself as Vicky, and I explained to Vicky the challenges that I'd had with Rodney's previous care, and she just said, look, we can't change that, but let's move forward and let's see how we can make this better. Rodney and our family felt like it was home. It felt like you'd literally gone to your home, but you weren't at home, if you like. And a sense of relief and emotion was just unbelievable. And I felt actually really safe leaving Rodney there, which I've got to say I'd not felt before. And I felt that they gave me peace of mind, and the staff had it, and they had us, they had him, and they were going to look after him. Reflection back on that day is that was a turning point. I felt like Rodney could actually have a future. Instead of mourning his loss, I was actually celebrating his life in a way, thinking, wow, I have actually got somebody that's going to help me here. And that is exactly how she made me feel. Butley Green is, obviously, as you know, a rehabilitation centre, and Rodney was a very, very poorly man. And I've got to say, I was a bit worried that, Rodney had gone into Butley Green and for rehabilitation, but really, in hindsight, he was in a totally different place. It wasn't rehabilitation Rodney needed, it was actually a chance to live. And I felt that although my frustrations were very, very heightened, I felt a bit untrustworthy of everybody at this stage. And the evidence, what I saw, where the way that Butley Green work and the way that Vicky and the team work were, let's get him to this stage of actually being stable. I witnessed some fantastic one-to-ones with people there. This wasn't just Rodney, this was people in the old place where, I witnessed one-to-ones where Vicky would come down on a daily basis, and she would ask everybody individually if they were okay, if they needed anything. At one point, I actually encouraged another patient's daughter to go and speak to Vicky and explain how she was feeling. She said she wasn't happy with some aspects of her mum's care. The daughter relayed back a positive experience when I said, go and speak to Vicky, knock on the door, it's always open, go and speak to her. She came back, she expressed how happy she was, how the meeting had gone. She explained that Vicky took on board points that she'd said, reassured with points that she'd probably overthinking, and really kind of, made her feel like she did myself, and I know that she did with others as well. She even wanted Vicky to come to her mum's funeral. Mum passed away after leaving Butley Green, and she wanted Vicky to come to the funeral because she said that she made her mum's last couple of weeks of her life really happy, really secure, really safe, which is fantastic. One of the things I can remember most of all about Butley Green, apart from all the above, was how they, team at Butley Green and there's a GP called Mary, immediately took over Rodney's care. Took it by the horns and basically read up on his care, put a new plan in place, evolved catheter treatment at Christie's, got involved with other people, other professionals to try and pull Rodney's journey more forward into more of a stable journey, if you like. I can remember Vic and the team really being on it and not letting it go, even though we'd not had a great journey with Christie's and obviously Oldham Hospital. It really kind of spoke volumes that they would, they've got a plan of action, they got dedicated people involved. They did above and beyond. They didn't have to do all that, but they did. But that was the tone that Butley Green sets. Whereas, you know, you're not just in there. They will help you stay out of hospital first and foremost. They will be an advocate for you. They are an advocate and a caring community, and it's not like, if you like, professionals getting round a table. It's hands-on. What are we going to do to make Mr. Howar's life livable and prevent Mr. Howard from going into hospital, because that was one of his biggest fears. And is still his biggest fear. He does not want to go back into hospital. With the experience he had, he felt, I don't think he'd survive a long stint in hospital again, and it was quite clear the team was going to keep Rodney safe, alive, and getting treatment he needed, which is such a benefit for us as a family. They understood the anxieties, they understand the pressures, and they don't just say goodbye when you leave there either, which is profound, really. I remember having a conversation with Vicky about Rodney's mental health, because he'd been in hospital and out of home for a long period of time, and we came up with the answer of, Vicky said, I need to get Rodney home, and I'm going to get Rodney home, and that's what she did. So the day he was discharged, I'll never forget, it was really emotional. The staff lined the corridors and clapped as Vicky asked for the honour of wheeling Rod out. He made such a big recovery and so many friends there that I knew that he was very, very nervous, and me too, to be honest, that, you know, he was going home and we were actually going in the big wide world without our Butley Green family, which was really, really difficult. And even though that I've got to be truthful, I was really nervous. They made it incredibly simple. They came to the house beforehand to make sure he had everything he needed. They made sure that with Vicky's out, she made sure that she helped me with carers in place. She just made sure, and so did the guys, that, you know, Rodney was more than welcome to come back to Butley Green at any time to visit, and that this is not goodbye kind of thing. And in all fairness to her and the team, you know, Vicky made sure that me and Rod felt right and safe, because I was taking on what was a quite complex person that had been incredibly poorly. I was taking him home and in effect running the show on my own. So that was very, very difficult. It's really difficult when you've been into a place where you've had a really bad experience and you go into a really good experience, because you don't want to leave that experience, because, you know, we were brought in several times at Butley Green saying, Rodney is very, very poorly, Joe. You know, you need to get your head round. You know, he's come far, but he's still a very poorly man, and, you know, we're here if you need to speak to us, which I've got to say I did a lot of. I did a lot of crying. Vicky had the patience of a saint with me, really. And we left that day, and from that day to this, I can honestly say the experience that we had at Butley Green was unbelievable. Matter of fact, I'll go so far as to say if they had room in the car park, I would get a learning academy and actually to show people how nursing should be, because I'd witnessed so many times and felt like a number, not a name, and almost like the people just didn't want to treat Rodney. Whereas in Butley Green, from the top of the chain right to the top, from Vicky to Jake and the team, right the way down to the cleaner, you felt like you were part of the family, you were listened to, and they made you feel totally protected. You don't find many people like Vicky in the team. It's one of the few angels left. The whole team at Butley Green is fully committed in healthcare, in the patient. It's not a job, it's a passion without a shadow of a doubt. And all I can say is, obviously, I wanted to speak to you guys about how Butley Green is, and it wasn't just for myself, it's for everybody that goes in there. How they make you feel as a patient, and it's absolutely apparent that you're a patient, but you're also human, and they don't treat you like a number. They treat you like a patient that needs help, that's vulnerable, and the door is always open. So I'd like to thank, on behalf of myself and Rodney and my family, Butley Green, and if I ever needed a facility, rehabilitation, anything like that, I wouldn't hesitate to send myself, my children, my grandchildren to Butley Green, and indeed my parents. And I do feel that Butley Green, regardless whether Rodney had me as an advocate, would have been absolutely just the same. Witnessed it with my own eyes. I've even seen Vicky go into somebody's room, say hello to them, and them ask them to bring the teeth back from the room, and she's gone up to the room, got the teeth, and brought them back to them. That's dedication. So thank you, Butley Green, and thank you for this opportunity.
Such a shame for such a profound story from carers through the carer's lens, and her name is Joanne, that she's not in the room. Had she been in the room, it would have been even more impactful emotionally, because through her story and through her lived experience, we're making an emotional connection, and we are reminded not just of our values, but actually how hard our colleagues work across the ACN, and in this instance, in Butley Green. The salient points that were mentioned from Joanne, a warm hug. If she was in the room, I would give her a warm hug back for allowing us to enter into her life and really have a sense of that experience of caring. And the vulnerability that she shared with us is very profound for parents. And when you're looking after your loved one with cancer and other comorbidities, the uncertainty that you live with is also very profound. So she mentioned that she was fearful going into Butley Green. Her fear was real, her anxiety was real. And yet what she encountered was not just the warm hug, but the opportunity to suddenly relax. It happened over time, but it happened with that intimate person that Vicky and her colleagues were able to convey, not just to Joanne, but to give a sense of life and purpose back to Rodney. That isn't something that just happens. You have to work really hard to get to that point. You have to be compassionate, you have to be kind, and you have to understand your impact on others. So our values of care, appreciate, and inspire were absolutely demonstrated in this story. And to help somebody feel safe, to help people feel they have a return to life and that life has purpose, to feel like you can celebrate life with your loved one, particularly when you think that you're losing them, and also to feel the comfort of that care, so much so, and have confidence in that care, that she was able to speak to another carer and say, go and speak to Vicky. She was inspired and she felt safe, and she knew that Vicky would resolve her issues. So these are just a few of the elements I captured, and of course we can take much more time in the story. But I'm delighted that it came to the board today. I hope it resonates in the same way it has with me with all of you. And I know with confidence that these are the values not only that we inspire to demonstrate, but absolutely are in and outside of the NC. I'll just pause there to see if there are any comments or questions. Heather?
Thank you, Chair, and I absolutely echo what you've said. And if I may add to that, what you described in terms of the values really underpinning the expert care and compassion that Rodney and his carers experienced and witnessed. I would also say that it's about the attention to what's required in terms of their profession to deliver the job. For people who know me, recently I've been preoccupied with the word clinician and how we see ourselves in the clinical community delivering care. The skill of a good professional is when families don't see you as professional at times, and they instead feel your warmth and the translation of you being proficient in medicines management, clinical effectiveness in end-of-life care, that translates to a compassionate experience. And it's also a chance for us as a board to have line of sight one of our areas. And of course, you would not be surprised to know that Butler Green has been rated green on the community assessment and accreditation. This is what green looks like. This is what green feels like to a family. And that's why we pay attention and we keep those standards very, very high in order that the human experience is one that's worth experiencing. So I just wanted to say that what Rodney experienced and his carer shared with us belies the professionalism that underpins that patient and resident experience.
Absolutely, and head on behalf of the board, please convey our thanks to Vicky and the husband team. The fact that everyone in that team experienced and demonstrated the same values is wonderful to hear. So thank you. Colleagues, can we now move to the main formal business of the board? We move to agenda item 3, apologies for absence received from Mrs. Harvey Goldwater, our senior director, and Mrs. Sue. We move to agenda item 4, declaration of interest. Are there any declaration of interest that colleagues would like to tell me about? No, thank you very much. We move then to minutes of the previous meeting held on the 2nd of October. Can I have confirmation that those notes of that meeting are a true and accurate record? Thank you.
Thank you, Chair. Just a correction, and I can email this to Jane line, but on page 6, section 9.2, towards the end of the paragraph on the last sentence, it refers to recurrent cost improvement of 65.2 million. That should read 64.2. It's a minor correction.
So thank you very much for that, Craig. Are there any further amendments? Owen?
Thank you, Chair. I've got an amendment, a couple of amendments. Page 18 of 24's minute 11.2. There's reference to the anchored people strategy. That should read anchored people strategy. And also page 19 of 24, minute 13.1, is referenced to patient care, and what it should say is efficiently directed to patient care. Again, I can give the detail of that to Jane.
Thank you very much. Are there any further amendments? So, yes, then. Good.
Thank you, Chair. Just a minor typo error at the bottom of page 1. There's a mayonnaise ends with a B.
Thank you very much, Gertie. So those amendments noted and then be updated in the minutes. Can we now take the minutes to be accurate? So yes, you can speak to me. Thank you. Yeah. Agenda item 6, matters arising from the previous meeting. Are there any matters arising? I haven't received any, so we can continue with the agenda. In terms of the action tracker, they're updated as you can see. Are there any questions related to any of the actions as they are presented in the papers? No. Thank you very much. Agenda item number 8, finance report 8.1, report from the finance committee. I'm grateful to Jack is going to take these because Sue is great. Thank you, Jack.
That's yeah. In Sue's absence, committee met on the 30th of October, halfway through the financial year. Craig will take you through the position at the moment in more detail, but the committee discussed in the context of a continuing deficit for GM providers that we are making excellent progress towards our 85 million cost improvement program savings target for this year. We were careful to stress that we're maybe halfway through the year, and particularly we need to convert more of our savings into current savings if we're going to make similar progress next year and the year after. However, the exec team, I think, can be congratulated on progress so far. If we do succeed in getting that cost improvement program before this year, that will leave us with £75 million deficit, which will be covered all our 4 billion by the more than 75 million, which NHS England are putting into the GM system. Our share of that will come deficit this year. And then next year, the year after, we have to make it about 85 million, which is why the current issue is so important. And the committee also had a good presentation from the Better Care Organisation on their contribution to the financial recovery. I should say that the Better Care Organisation, with Owen's input, also discussed a very exciting meeting they had had with the Better Mentality Board, with lots of future changes in the pipeline from those discussions. On capital, it's now clear to the committee that we will not get the £26 million of funding promised to support the transfer of penile care services to the trust. We were told that the council group are addressing that by cutting our programme as far as we can. We're also seeking alternative sources of funding along with MFT through GM sources. Other reports discussed were on estates facilities, internal audit reports affecting finance, and the meetings with the GM ICB board, which will be covered in more detail in part 2 of today's agenda. We also have a very helpful analysis of the reasons why our workforce has increased since pre-COVID times and how we expect that increase, where it's not come from additional income, to be reduced back to pre-COVID times. And we discussed the context of that productivity. Finally, Chair, in terms of risks, we added a risk, in particular on the pay award, which is still to be confirmed, maybe some details of that later. And we noted that we are continuing to monitor the risks in relation to the fire safety in work with all the state's facilities. I'm speaking there, Chair.
Thank you very much, Chair. Are there any questions or comments for Chair? No. Can we note the report is received? Thank you. We move on to methods of escalation. I'm going to invite Craig to speak to the financial position report for month 6, please.
Sure. Excellent job, Jeff. That was covered a lot of my points I was going to make. So I just want to add a little bit of context to what Jeff was describing on the 175 million deficit funding that GM received. So just to reiterate what that means now, for month 7, when we start to report, we will start to report about against the deficit plan of 4.3 million deficit. And that's because, as Jeff's described, we started life at 75.7 million deficit, but we've received cash to the tune of around 71.4 million. So we reset that plan. We start to talk towards that plan from month 7 onwards. In terms of the CIP, I'm happy to say that since the report, it's edged a little bit further towards the main target. So in year, inclusive of pipeline, we're now at around 98% of the target, which is 83.7 million. Of that, we've transacted 60.2 million. So we've transacted 72% of what we've identified. I think the main focus now, if we can get over the line in terms of that 85.6 in year, is the recurrent transaction and follow through into next financial year. On the recurrent side, there is a lot more work to do. So we've identified 55.6 million, which is actually 86% of the target for the recurrent side, which is really good. Where we're trailing a little bit is what we've transacted. So we've transacted around 25 million of that identified 55.6. And that's where we need to target our focus now and effort in terms of translating those through. Because anything that we don't translate through into a recurrent scheme has a subsequent impact on the start position of the FSP and the financial sustainability plan, and it will worsen that position to the level of what we undershoot on recurrent. So that's an important point. And just on the cash situation, with this injection of cash now to satisfy bringing us to a £4.3 million deficit, I don't envisage any cash issues for this trust for this financial year now as a result of that. So when we work that through, that means we won't be in a situation where we're asking for emergency funds, which is good news. But just horizon scanning ahead, picking up on a couple of good points, is we do still have a capital issue across GM where we're oversubscribed against our target that we're allowed, and we are continuing to work on that. The NCA itself has reduced its plans, but that contribution, when you add it to everybody else's reductions, is still not there as a system yet. We've got about 30 million as a system to find. And as Jeff has mentioned as well, there's some things that are generic across all of us that we'll need to bring back to board in month 7 around understanding of pay award pressures, not only for the NCA but across the system as a whole, and also specifically to the NCA, some emerging pressures on adult social care packages, which is highlighted in the report. And we will have line of sight to some real-time data, or as real-time as it gets, I suppose, month 4 data for income for this financial year that we can assess in month 7 to see where we are in our performance against the elective recovery fund. So I can bring some of them insights back in month 7. I think that's all. That's Chair. Thank you.
Thank you very much indeed, Craig. Are there any questions or comments? I think we've heard the headline, particularly on transaction pay award. So month 7 is going through the crucials until. Tim, oh, sorry, did you have that? Sorry.
Thank you, Chair. Thanks, Greg. I mean, there's lots of positives in there, not least the kind of sustained progress on cost improvement, all that delivers that. But just a couple of quick questions. One's on capital. I'll take what you described just on capital, but we've got slippage on that, so it's just making sure there are not barriers to us actually delivering in this year. And the other one, it looks like, I know at the Finance Committee we looked at the increase in bank expenditure. Recovery actions seem to be delivering. So it's just that confidence that those recovery actions will deliver that reduction in bank expenditure.
Yes.
So in terms of the capital point, you're absolutely right. We have to make sure that what plan we are working to, albeit a reduced one, is spent, and we are reprioritising the capital group and bringing some updates in Finance Committee. I believe a forecast was shared at Finance Committee, and I think it's getting our confidence in that with the people who are spending that money now to give that assurance to Finance Committee that we do spend that money, because it's really crucial that we do that. In terms of the mitigation plans and the bank spend, that was one of the key areas. We were looking at both a volume of shifts reduction and a price change in rates reduction, and we are in the process of about to conclude the process of the rate reduction. But we mitigated it, or we put into as a mitigation plan. So that is in train, Tim, on that, and should subsequently flow through into the next prospective month's positions. And the volume reduction, Heather, our Chief Nursing Officer, is continuing to look at those on a fortnightly basis through the nursing group that she chairs. So I'm confident we've got processes in place not only to enact those, but to monitor their progress as well, Tim.
Thank you, Tim. Thank you, Craig. Any further comments, Jude? And then Jeff. Let's have a first. Oh, sorry, Heather.
Thank you, Chair. Thanks for the question, Tim, because on the confidence of the mitigation, and that does relate to, for me, your question. I took it to ask the board to just appreciate the decision making around reducing the enhanced rates in high acuity areas, in particular our intensive care units. With some confidence, I approve the reduction of those enhanced rates because of the vacancy factor. What we are therefore more vigilant around would be the sickness element and how that impacts on our ability to retain the level of uptake of bank shifts when needed from colleagues who might not want to do that because of the reduction in rates. So that's the key issue. Would patient safety be affected? And we are confident that our mitigations are strong enough and effective enough to plug any gaps from a lack of uptake of shifts as a result of the price reduction. It might seem conservative, but the conservative element of it is to ensure reliability that will be delivered. And what we don't want to do is impact on patient safety by pledging even bigger savings and reducing it even more. But we have absolutely, if you like, kicked the tires on that recommendation to ensure that we preserve patient safety, but we effectively reduce the enhanced rates in those high acuity areas.
Jeff, please.
The odd chair was not to, in discussing finance, note the national budget last week. And I suppose my question would be, do we have any idea yet when the impact of that will be understood at our level? And I'm thinking particularly of the timing in relation to our planning process of refreshing our financial sustainability plan. And just a quick remarks to this, whether there's any indications yet in the system about how the increase in national insurance will be dealt with. I know we should be fully funded for that. I suppose my query is possibly around adult social care with duties, whether we are confident that will be covered as well before. Thank you.
Thanks, Jeff. Yeah, I mean, might have been conspicuous by its absence there in terms of not mentioning that specifically. The main reason I haven't mentioned it, Jeff, is there's no news on it. Formally, there's no news. The only formal message that I'm going to say aboard is that there is no money coming in to support the pay award, was the message earlier. So the pay award pressure that I described will potentially be an issue that there have been a couple of briefing sessions that were put in this week, but they removed them as quickly as went in, and they are going to rearrange to brief us on that, Jeff. So apologies, I have no new news on that.
Thank you. Jude. Oh. So covered by this. Thank you very much. I suppose just on the last question that Jeff posed, we also need to be mindful that there will be some reforms coming in, particularly regarding the 3 shifts and system change and how that's going to impact in the context of prevention. But I think we need to keep a close eye on our financial plan and ensure that those particular unseen and yet and very uncertain impact will the implications. Thank you very much. So, colleague, can we note then, for completeness, that the recommendations 1 to 6 and the financial position paper have been noted. Great. Sorry, thank you. So we move on to quality and performance, and I'm delighted to inform colleagues that Dr. Chris Harrison has very kindly taken on the role of chair and released me for a short time. My responsibilities in that respect. So we now turn to you, Chris, to give a report on quality and performance. In 9-1.
Do I need to press this? Thank you, Chair. It falls to me to give a report from the Quality Performance Committee, chaired by Lena, but I was there, so I will give the report. The committee meets every month, so last time we had feedback, I think we noted, didn't we, that you've given quite an extensive report, Rebecca, because of the range of things being considered by the committee and also the serious issues that were being grappled with by the committee, but more directly by the executives. And it was important that the board was cited on all of those issues. I think it's true to say that at the most recent meeting, many of the same issues were being looked at and followed up and further work undertaken. And you'll see from the papers the range of things which were looked at and discussed. And you'll also see the in terms of risk, the BAF risk, BAF 8 is which what is it? The BAT risk. I've got the financial report in front of me, but that won't help. You'll also see the risk in terms of BAT risk 6, it is, and the continuing high level of risk score against that risk, which is about responding to quality standard and quality system failure. So that remains, I think, as we said last time, high there, and it illustrates the level of risk being dealt with across the organisation. If I focus on the matters for alert raised in the paper, you will see that first two of those alert issues really relate to performance questions, and as the committee heard, although there were improvements, the trust has not yet been meeting the requirements across elected performance, urgent care performance or cancer. I'm sure in the later papers Jude will update us on the current position and mitigations on those issues that we did have in terms of the board, but we did have considerable discussion at the Quality Assurance Committee on those issues. But it is the case that currently we're not in the area that we're expected to be in. There's a very specific item on here about nasogastric tube management, which is very specific, but actually is very important. So we had considerable discussion at the Quality Assurance Committee about this. It's one of those almost symbolic patient safety issues that has been problematic for some time. And I think, Rafiq, you have we heard in some detail, you weren't able to be at the meeting, but we heard in some detail that you have a process for dealing with that. I'm sure you're in contact with medical directors up and down the country who have to deal with this particular issue, and it is one of those things which is important to address. You see also some of the advice issues here, which I won't go through, but I think it is important to come to the assure items 7 and 8 on the front sheet here. So good to note demonstrable compliance with Regulation 18. That's the some of the issues to do with staffing development of the workforce, nursing, being in the top 25% nationally for a particular measure. So I think it's important to note that. And also, I'm sure Jude will bring this to our attention, but assurance that in terms of 52-week waiting lists for planned care is ahead of trajectory. That's the information that we were getting at the Quality Assurance Committee. So I won't go through the rest of the report in detail. As I said, many of the issues are the same ones that Chair Ravina raised at the previous meeting. There remains a high level of risk. I think it's important that the board is fully sighted on that, and also that thanks to the executives and the members of the committee, the committee has scrutinised some of these issues, or scrutinised these issues in some detail and at some length.
Absolutely. Thank you, Chris. Are there any comments and questions, colleagues, on this paper? It is true. It is a very comprehensive and detailed scrutiny that we gave in the Quality Assurance Committee, done so by the very nature of the topics and the areas of service that we are looking at. And so we do really dive in depth, and the AAA report reflects that discussion. So thank you very much, Chris. Can we note, please, colleagues, recommendations 1 to 8 have been met? Yes, Jeff.
Chair, before we do so, can I just raise one specific? That is the alert about a lack of slots for looked after children having their health assessments, and wasn't clear from the wording whether this problem was temporary and that's resolved, or whether it was leading to potentially not getting their assessments within the timescales. So that's the case. Obviously, there's going to be significant issues for our partners and the children themselves. I was wondering whether either here or offline there's a bit more detail about those. On a happier note, I was really pleased to see in the report the days kept away from home collaborative and the discharge program team involved.
Thank you, Chair. Jeff, happy to take your query offline about the looked after children notes, because that is an issue being actively managed by our head of safeguarding, and how we mitigate that with our local authority colleagues. We're happy to talk you through that. Repeat.
Thank you, Chair. I just wanted to assure the committee that the nasogastric tube issue is something that is taking some considerable focus for us. I was also away, but the day of the committee so wasn't there, but had brought up since there's a task been finished with that's looking at this. Has been a recent tweak to our policies. I think the matter I'm concerned of requires us to focus on at the moment the level of training in the organisation, which between myself and Heather.
Thank you for that. With the data initial certainly. Sorry, colleagues, I didn't look at this new machine. It's a wonderful data timing. Who wants to speak? There's what seat number is it as? That's why I can move straight to the recommendations. Can we now move to the recommendations, please? 1 to 8. Can we note them?
Read.
Thank you very much. We move then to matters of escalation. The permanent quality surveys report, which will be presented by Heather in the absence of our colleagues. Thank you.
Thank you, Chair. Just to remind the board that, or inform the board that our maternity services are currently being visited by our local maternity and neonatal service, jointly with the regional team, maternities team, in order to conduct an independent assurance exercise on the service. And that's why no one from the perinatal quad leadership is here to present the paper. So I will be doing that on their behalf. So many thanks. The paper, I with confidence will assume that it's been read, but I just wanted to, in terms of framing some of the things that are in the report, the things I'd like to draw the board's attention to are the continuing attention the service is paying to workforce pressures, both within midwifery, the midwifery workforce, and also obstetrics. We are roughly running at about just under 50 full-time equivalent vacancy factor amongst our midwifery colleagues, and that is being managed quite comprehensively, I must say. It is a relatively, it's a better position than it was at the time of the writing of the report, or the period of the report, and previous months, due to the effective recruitment campaign to get to attract colleagues to the service. And a lot of our student midwives are choosing to stay with us. It's an around-the-clock challenge and commitment, and also some creative solutions, as I've mentioned before, registered nurses supporting midwifery colleagues with high acuity interventions which do not require midwifery input. For our obstetric establishment gaps, we have 4 full-time equivalent vacancy, and that is being managed through locum colleagues. So in the face of that, we were still able to ensure that all shifts during the reporting period had a supernumerary coordinating midwives. And what that means is there is someone having a helicopter view and being able to go into the numbers if there are some significant gaps potentially impacting on safety. And we were able to 100% deliver one-to-one care, which is quite significant. The other thing, just to draw your attention to, would be how we are progressing against the national NHS resolution for the incentive scheme, and for actions 4, 7 and 8, we are declaring amber, where we would need to pay some attention to us ensuring we deliver on our workforce measures. I've just described some of the issues we're doing there. Service user feedback, so I can report that alternative voice partnership colleague or partner is in place as of now, and our self-assessment, can't read my hand. In terms of our staff training, we are currently non-compliant, but the measures that we put in place with the specialist education midwife, which I have to say is not just focusing on midwifery colleagues, but all colleagues requiring that training. There is a sort of check and challenge, nudging, monitoring, overseeing function that role plays to supplement all other efforts to ensure that we will get to that 90% by December. So those are just some of the things that I wanted to draw your attention to. There are other things, and so happy to take any questions from colleagues to clarify if it's needed.
Thank you, Heather. Are there any questions or comments or points of clarification? So we have Rufi and Chris.
Thank you, Chair. Just an additional comment, just what Heather was referring to. So executive recruitment has been a massive challenge. It's a bit of a massive challenge nationally, but we've had some significant gaps over a period of time. There are some interviews that are going on next week to try and cover those gaps, and with our team focus on gynecology and gynecology resilience, we're also looking at how we can sort of cross-cover, because we still have a joint rota with the same cohort of colleagues who cover obstetrics and gynecology. So just to provide some additional assurance that even though the progress in that space has been slow, there are indications that we're heading.
It's really good to hear that. Absolutely, this is important if you don't have the right staff in the right place at the right time. It impacts on our patient experience and on the care we want the ratio to be right, don't we? Thank you. Chris, please.
Just to ask Heather, on section 9, the incentive scheme, you've given us a great update on where we are currently. Just wondered if we had a sort of projection of where we think we're going to end up on this. Do we think we're going to end up declaring full compliance, or are there some areas that we're going to miss on?
We are projecting full compliance, Chris.
Are there any further questions or comments, colleague? No. Can I ask a question around additional supports that's required in terms of education to sustain our NICU admissions?
Sorry, could you?
The reductions. You mentioned that education might be compromised, and I'm particularly looking at neonatal staff and neonatal units. Have I misread that?
It's I will have to look. Sorry,
it may be something that I picked up in the Quality Performance Committee when we went wide education and training compliance, and I'm just relating that to the education and training of the staff, because specialist training in education for those involved in neonatal intensive care unit.
Yeah. So with regards, sorry, I was just thinking in terms of the incentive scheme and the prompt training, the multidisciplinary training. So that is covered through the specialist education midwife that we've got. We received assurance this week in our accreditation group just yesterday about the improvement programme for the neonatal service, including any educational and attain from the attain assessment. So we will be able to report next on assurance on that. But from the update yesterday, there were no concerns reported from the team on that issue.
Thank you. So colleagues, if there are no more questions or comments, can we agree to note all of the recommendations? They're not exactly in order, but we're happy to note. Thank you. We move on then to the learning from experience reports. Again, we are with Heather, agenda item 9.3.
Thank you, Chair. So this is the biannual learning experience report covering April to September. So slightly late, but just detailing all the work that's happened over the past for that 6 months period. It's a 47-page report, which does include a very helpful summary at the start. But I think in general, what the report does show, it gives some insight into the significant work happening across the organisation to ensure that we have that attention to patient safety and quality of care being delivered to the standards we would want and we're able to. With the one thing I suppose I'd pick out a couple of things would be the advancements we're making around the PISA implementation and replacing root cause analyses with a SEEPS model, which looks at system thinking, system engineering thinking, focusing on human factors, tools, the environment, psychological issues, and having witnessed this over the past few months, colleagues are getting more familiar with that, being curious and inquisitive around contributory factors, not just looking at the root cause, but what are some other issues contributing to that. In a variety of forums, you've mentioned our incident management system, DATEX, and I think DATEX has, it's coming up in these SEEPS investigation when colleagues are thinking about the tools that they have to help with their learning. And so that's the other thing that's buried in this report. We are gaining momentum and understanding from colleagues about how this is getting in the way of helping, hindering the learning when things go wrong. So I think the piece of movement, we're still in the early stages, but we are seeing evidence that is that will help us as a learning organisation. And just to supplement that as well, you would have seen the days kept away from home, some detail around that project and that data, and the project that were presented in June by nursing and midwifery colleagues around their quality improvement programme. That you have a snippet of some of the projects that were presented there. I will stop there just to get any questions or comments.
Thank you, Heather. Are there any questions or comments? You. Yes, we have.
Thanks, Chair. Thanks, Heather. I mean, you've lifted out the point I was going to ask about. I mean, here and in quite a few other places, there are oblique and direct references to DATEX either not being quite right or people not using it properly. It's such an important system in a lot of places for the board. Just having a bit more clarity on, are we procuring to get a new system in the time frame, or are we just kind of nudging DATEX around a bit? It's kind of that sense. It sounds as though we're procuring a system. So be clarity on the process where the board would see that develop.
Absolutely. So under the we are procuring a new system, and that's being led by a task and finish group, which Nikki Hancock's from Lorna's team, and also Jackie Burrow from my team, and Kirsty MacDonald are looking at various systems, and we are going to visit some places that are using alternate systems. There are solutions that are more local in GM. One of the mental health trusts, they are using a product that we were looking at, which I wouldn't name here, but they were looking at a system that we were looking at, which is it does do quite a lot, and it's you can engineer it for your own needs, and we're scoping that in addition to other another system that's used elsewhere. I think Norfolk. I'm just remembering some of the places that we're going to look at. We're being helped by the digital team in order that we get the right products and systems to align with other things that we are using. In addition to that, of course, we are trying to gain an understanding of people's as users of DataX. What are some of the key issues? And there is a survey that has been carried out, and we're going to review that. That will contribute to the plan to implement the new system. The Green report and the Green recommendation also is another place where data excited, and that is what's driving the solution around DataX and it contributing to our patient safety improvement processes in the organisation. So we are procuring it. We are also trying to improve the system that we have, and the way how investigations are happening, the learning as well, that's contributing to our continuous improvement around DataX.
Yeah, thanks. So, yeah, I mean, it's an obvious one, but I just urge that as part of that, we kind of also look at the behaviours and culture and people's kind of confidence in declaring incidents and raising issues through whatever system it is. I guess that's a big part of it as well. So
yeah, I mean, the cultural part is a key thing. So what I'm also doing with my top team, just last week, we had a session on data specifically, how our colleagues assured that their concerns are being responded to. And I've asked all the directors of nursing across the different care roles to write to describe their assurance processes about how learning has happened, recognising that not just nurses and midwives who use it, but we are the biggest workforce and are more likely than not have a managerial connection to a clinical area. So what's the assurance that not just concerns that are moderate or high or severe that are looked at, but incidents that are no harm, low harm, near misses. There's a thematic analysis being undertaken to ensure we get a sense of the things that are coming through. So that those reports will give us a sense of where the gaps are in our ability to learn from what people are putting on the system. So that piece is also happening along with procuring the system.
Thank you, Tim. Chris, please.
Thanks. I have to say, I thought this was great. It's a great report. And the reason I say that is that I think what it does is attempts to move us two directions. One, from thinking about the systems and the inputs to what the themes and the outputs are, what the solutions are. So I think that's, the second thing is, I thought it was great that it was trying to pull together themes from different sources as well. And I think there's more to do, more to go there, so that some bigger things would emerge. But in terms of learning, we often do tend to get stuck, don't we, in identifying the problem and what we might do, rather than what have we actually learned and have we changed things. And I think for me, this is why this report was really welcome, because I think it starts to get us in that direction. So I'm hopeful we'll see more of that.
Thank you, Chris. Yes, we will.
Thank you, Chris. So very interesting conversation just then. So we started with Tim focusing on confidence. Data has been problematic. But while we transition to the new system that's going to be procured, how do we enable staff to continue to use data so we can have the data to deliver the shared learning? That's very important. And then the opportunities that Chris has just mentioned, it's key for us to achieve all of our milestones in terms of how we deliver care and how we perceive care is experienced from our service users, carers, our patients, and indeed the population we serve. The only way we can do that is by demonstrating that we improve based on the learning that we have embedded and the change that has emerged from it. And that does require a cultural shift, quite a massive one, and a behavioural one. And a behavioural one linked to our values, care, appreciate, and inspire, which need to be fully instilled and visible in all our partners and family across NCA. So I think it's a really important report. It isn't something that's going to go away. So I'm pleased it's here and will continue to come with future developments and how actually it's delivering the change that we see in the context of what we've just described.
Absolutely, Chair. And just to also, for your diaries, in January there will be a bit of an exposition of some of these projects, which our colleagues will be able to demonstrate any movements from what's been referred to in this report, what the progress has been. So that's planned for the intercession between parts 1 and part 2 next board.
Thank you very much, Heather. So, colleagues, again, can we agree to the recommendations and note them? Can I hear some voices?
Agreed.
Yep.
Thank you. We move then to an equally important report, learning from death, and that's with review.
Thank you, Chair. Thanks, everyone. So 4 times a year, we look at learning from deaths across the organisation, and this goes on for a cycle for us. So this is for the most recent cycle. I'll draw out just a couple of things. So first of all, you note that there's a slight change in the way we're presenting the report this time round with some footnotes. We're hoping that this is going to be easier for both board members and the public to follow. And happy to hear any comments about this. Broadly speaking, our indicators in terms of SHIMI, HSMR, and group mortality continue to head in the right direction with improvements and us being below the national average on most of our indicators. We do have a couple of areas that have flagged that we are further looking into. The most notable ones being sepsis and our fracture bone indicators, which have been going in one direction. Sepsis seems to have made a bit of a turnaround, but we're continuing to look at that. Fracture neck of femur, we're doing a deep dive across the organisation to understand the reasons behind it, and we're expecting a more in-depth report in November once we have the full suite of data. Our medical examiner service continues to be compliant. We will recall that we referenced some changes in the statutory requirements that were coming in September. That transition has gone very smoothly for us, and just outside the hours urgent releases which sometimes impact our numbers, we remain compliant. We have had a dip in the SGR completion rates. We went from nearly 90% in our last reporting cycle to about 80% this time round. So this is something that we need to give a little bit more focus on. This falls on care organisations specifically that have had a challenge, and it's related to capacity, and the paper references some of the progress that we're giving in sort of trying to understand how we can expand the capacity by including resident doctors and nursing colleagues in some of these reviews. Also worth noting a neglect rider issued by the coroner for a specific very sad case where they were seen by our teams in ED on 2 occasions, and upon the embolism wasn't picked up because some of the investigations weren't done, and there's an action plan and some additional training that has gone in to try and ensure that that doesn't happen again in the future. There's some learning that's included in the paper just to indicate some of the work that is being taken out of learning from this and being fed back into the learning across the organisation. And I will post that.
Thank you. Before I invite colleagues to send questions or comments, can we not have any questions regarding the formatting? That's work in progress, so we will be having a discussion as a board on the effectiveness of how we look at reports and etc. etc. So open to questions, colleagues. Chris. It's Jeff.
Sorry, yeah.
It's Jeff, isn't it?
That's Heather. So,
Oh, sorry, Heather.
That's the thing.
Heather, thank you.
Thank you, Chair. And sincere apologies, I didn't take it up when I spoke last. Sorry.
Oh, so, okay, so,
Yeah.
okay, thank you. So seat 15, which was repeat, he was on, and now we are going seat 5, which is Chris.
Okay. Good things for me.
that's correct.
That's what it's saying.
It's correct.
And so it's not Jack. It's obviously not Jack.
No, it is you, isn't it? I'm like,
So, two things for me. One is the changes in the mortality rates are remarkable, aren't they, in that period? What was changed? What's different? Well, because I think we said this at the quality shows, if those figures were going the other way, they were going adverse, we'd be all over that data trying to find out what the reasons were. And is the narrative here that it's accumulation of these things that are listed below that's caused that? Because it's a really remarkable trend that both HSMR and chimney are going down in that way. I mean, often you get the two going in the opposite. So that was one thing. And then just in terms of the last thing you said about the pulmonary ambulance, your sense of, that's the sort of thing that happens, isn't it, in very busy A&E departments when the pressure is such. That's the actual manifestation of pressure in A&E departments coming vividly to our attention. Is that a fact?
Thank you, Chris. So in answer to the first question, I do think it's because we have a robust learning tests framework in the organisation. There's still some variation in terms of how we run M&M processes in individual services, which we're working to harmonise. But broadly speaking, we have a very robust system that has fed back learning and picks up on alerts reasonably early. I think it's clear from the data that this isn't a blip. We've had persistently for over a year progressive improvement in all indicators, not just one. Now, having said that, you may recall we did have a discussion last time around where we we were talking about maybe not being complacent and maybe doing some additional work. We know that we have challenges in corners of the organisation with some of the issues that we've had historically. So we need to apply a bit of skepticism to the direction that some of these indicators have continued to take. And so we've had discussions with Owen about possibly getting another, if you like, external look on additional support, just so that we look at this even more deeply to make sure that it is going to be sustained improvements and that we aren't missing anything. In relation to the second point, I think it's a very fair point. It is exactly what happens in that kind of situation. We are doing things to ensure on this specific issue that the learning is there, and I'm in the process of just making sure that it is that the learning is applied across all of our ET departments. But having just coincidentally yesterday, I was having a meeting with a large cohort of our clinicians who work in urgent emergency care at Oldham, for example, and they are talking about the concerns that they have and the clinical risk that is carried because of some of the pressures, ambulance queues, patients in ambulances that they can't really look at, that kind of thing. So there is no doubt that some of this will be contributing, and the wider improvement work support will help mitigate some of that risk.
Thank you, Chris. Are there any further questions? There's next. Yes, you are.
The next.
Yes.
Thank you, Chair. Chris, I think the thing's also reflected still a little bit of what I would call ongoing anxiety about kind of that HSMR and Chimney appeal. Would be that second guess the point that he makes about the robustness and the confidence in the learning desk process, but it still feels quite remarkable. And he's right, there is a colleague that we're looking to enlist who just give us a little bit of an overview, but that overview is more about understand the construct of shimmy and SMR and how that works. I just wonder whether what we might also need to do with Peak is just see, if you looked at our trend, just to see across the country, because we can look at other people's data, just across the country, is there anybody else doing a similar trajectory like that? I just think it would be just helpful to know whether we are, you know, amongst a group of several trusts that are in that similar patterns, or whether we're quite unique. Just to give that further sense of, I don't know if comfort's the word, but yeah. Yeah.
Yeah, I'm happy to. We haven't looked at that specifically. We've looked at sort of our trend compared to everybody, rather than to identify specific organisations that might have a similar trend to us. But I think that would be an interesting thing to look at. I'm very happy to take that to London.
Because if you look at HSMR or whatever else, and you look at it from October 22, either of them, that is quite a direction of travel. As Chris says, it's remarkable. It'd be just good to know, are there several other trucks out there that are experiencing that, you think about the financial construct within all the others. I could go on, but you get the drift.
Yeah, it's almost counterintuitive.
Yeah,
once it goes like in that direction.
May I endorse that same point? Because I think it's essential that we understand how the data is presented and not just accept the construct as given as the interpretation of the takeaways. It all seems like a positive, negative sometimes, and that can be disturbing because the numbers here are people that have passed, they have died, and that is not just important to note. We need to recognise and reconcile that the systems we have in place have not caused anything wrong, and that we are measuring our performance against those deaths in absolutely the right way. There is a sophistication to numbers, it's complicated, but I think when you look at a trend, you have to do that over time. And I think so we can sharpen up the data and be a bit more smarter. The national reference points will be slightly skewed depending on how they collect their data and how they code their patients. So there are further additional complications we have to impact. But clarity is absolutely what we would like to see more. And I'm pleased to hear that you're going to address this with.
Thanks, Trish. So happy to look at those things and continue those conversations. I do think it's important, though, to not take away from the hard work that teams have been doing. It's a 2-year sustained improvement. We need to apply appropriate skepticism to ensure that we aren't misguiding it, that it continues. But this is in certainly the small number of organisations that I've worked in before here. This is the most robust system that I've been part of. We should also just note that.
No, absolutely. Notwithstanding the point you just made, we recognise all the hard work the team is making, and we're in transition. But we have a real responsibility from a government's point of view and insurance point of view that we are indeed providing safe care, and it's describing the way that is appropriate and relevant to that understanding. So it's win-win because we're going in the right direction on both all of things. So thank you very much. So, colleagues, once again, can we accept all of the recommendations? I'd like to hear the cases.
Yes.
Thank you very much indeed. Thank you. We move then to agenda item number 10, and education, and that's going to be presented by Louise.
Morning, everyone. We met on Wednesday, 23rd of October. I'll take the paper as read, but I do want to just quickly go through 3 of the alerts. So the Guardian of Safe Working raised a number of concerns, in particular on the increase in the number of less than full-time trainees. Now, these are trainees that arrive every year, and there are more less than full-time trainees this year than there were the year before. And we expect next year there'll be even more. Now, we were not informed of this by NHS England and lead employers. So the way we planned all our rotas for these trainees was not fit for purpose. And of course, you can just imagine all the payment and issues that caused. We are looking at it being looked at. this year by the lead, the champion for less than full-time trainees and the chief medical officer, and we're looking at the rotas as well, actually. But also we're going to predict and assume that actually it will be an even bigger number this year. We're just going to work on that basis and plan accordingly, because that seems to be the way the world of work for young people is going. We were very concerned to see that the National Staff Survey Action Plan Progress update, that there was very little documented assurance regarding the staff survey action plans. Now, you know, we lauded the fact that our action plan, that our staff survey last year got 50% of staff responding. We wanted to hear what they said. And it may be that those action plans are being actioned. However, there is no documented assurance of that. And in some care organisations, there was zero documentation of this. And so, you know, obviously we've got a new head of HR, and we've talked about how we are going to go forward in terms of making sure that, as well as carrying out national staff survey action plans, that those actions are documented and tracked through the year. And especially at a time when we're going through another staff survey this year, that was concerning. It doesn't mean, and we know it doesn't mean that those actions aren't happening, but we need to be able to track them and evidence them, obviously, and present them to staff the next year and say, hey, you said this, we did this, and this is what happened. We met a week before the Quality Performance Committee, and we also discussed mandatory training. And I think when we meet in our subgroups about the new structures and committees and subcommittees, this is certainly one area, mandatory training, that we shouldn't be discussing at two committees. I don't know if you remember, but we know that our mandatory training is very good. It's way above 90%, but on People and Education Committee, we asked for a triage of which areas were we not meeting the 90%. And, you know, sad to say, one of them, it turns out, was nasogastric feeding. And we all know some of the results of nasogastric feeding not happening properly. So this was, you know, with the chief medical officer and chief nurse, we said, you know, we must meet 90% compliance on that. And that's all I want to talk about on the People Committee. Any questions?
We have a number of questions. So first of all, we have Owen.
Yeah, it was actually a question for Gertie. What Aziz has just described there in terms of the audit assurance doesn't quite connect with the sessions that we've had, and I know Aziz has attended those sessions where we're actually celebrating the responses and the action that has been taken against the staff survey. So I'm just interested about, is there potentially something where we are not sharing the information of the progress being made, perhaps, or I'm just trying the dichotomy there. You come to those events yourself, and we've got really illuminating stories of progress made. So I'm just interested if Gertie's got a view on that.
I think this works in that action. So there's probably a clarification in as much as there's the trust level staff survey action plan, where we pulled up the areas that are consistent themes, and there'll be a lot of the areas you see in the sessions. What the concern we had at the People and Education Committee was specifically the areas in each of the care organisations that they said as a care organisation they were going to work on. And again, as Aziz has said, it's not that we feel that they're unlikely to be doing it, because clearly when we speak to the care organisations, they can articulate it. The concern is that they're not documenting it, which leaves us in a position where we have no assurance as a committee. It's a matter I've picked up at our most recent senior management team with all of the care chief officers. And again, they gave assurance that there's an awful lot of activity happening in each of the care organisations. But I've reminded them that if it isn't documented, it isn't happening. So the proposal of having care orgs coming to, as they do biannually, to the People Committee, but specifically asking them to also document and update their staff survey action plans is a positive way forward, so that it's not falling on the centralised colleague experience team to repeat this fact. It's owned by the care organisations. It should be fed back by the care organisations. I'm not sure if that answers the question.
Sure, I can answer the question.
Oh,
I think I'm tough now.
nobody's gone green today, so
I think I've obviously got some special condition. I don't. If you take an example, so yesterday I'm doing various ward walks in Oldham, and we're able analytically by ward to understand what the performance of that ward is in a 2023 staff survey, 2024, and we're able to also identify some of the key areas of improvement that have been addressed. And actually, when you then speak to some of the say ward leadership, people can actually articulate what they've been done. That suggests that there is a degree of understanding. So, but I wonder if there's an issue around capturing, but also I take the point you make about ownership in the sense of if that analytical capability is largely the colleagues that work with you, that's the point I take. And if that's the point we're making, then I think I just want to be clear about that, because it does feel like we're quite data rich around this. So that's why I'm just wanting clarification, but that's fine. We can pick it up a little bit further, just to be clear. Thank you.
Thank you, Heather.
Thank you, Chair. So I just wanted to, on a point of clarification, when you said, Aziz, about the us having really impressive levels of really impressive levels of mandatory training, and yet nasogastric training is significantly low. We do need to make the distinction between mandatory training and job essential training. And the reason why that's important is because I've taken to task the Nutrition Steering Group Committee, which will be the group that, if you like, has oversight of the subject matter expert who informs the training, who will then liaise with colleagues and leads in those areas who need to have that training as part of their job. So job essential training is, if you like, some might argue it's more tricky to manage because it's pockets of colleagues based on their job to do that training and have it done as and when they could do. And it doesn't negate the fact that our mandatory training is quite high. It's the job essential training that we do need to give assurance, I think, in response to your challenge. How are we managing job essential training compliance as we have managed mandatory training? So, and on the nasogastric specific issue, myself and Rafiq will take that in terms of it's mostly nurses who deliver the training, but it's there's a co-chairing of medical and a non-medical colleague chairing that nutrition group. So we will take that away.
Okay.
Thank you, Chair. So I just want to, I think, emphasising the point about less than full-time trainees and just understanding how problematic that is. It is definitely a trajectory people are choosing now to be more flexible, etc. But what it means is, because historically all of our rotas are built on essentially the assumption that people on rotas are full-time employees, all of a sudden a significant portion of our colleagues are choosing to work 60% or 40% or whatever it is. And so that means that it is very then difficult to find somebody who can take up the slack in the rota. And the deaneries have been, I think, less than helpful in terms of giving us the information sufficient in advance for us to be able to properly plan for this. So it is a massive headache for rotas and is contributing to some of the increased spending and lack of resilience in some areas.
Thank you for that point, Rafiq. I was going to say something very similar. I think we underestimate, we forget two things within NCA, that this is a training organisation. We have a number of trainees across all of our areas who service our patients. And as a result of the pandemic, there has been a massive decrease in trainees reducing their hours and extending their programme. And because of that, it does impact directly on how we populate rotas and be fair in doing so. We already have a very overstretched and tired service. So our colleagues are working in circumstances which can be difficult. But that's part of healthcare. There's also something that we need to be mindful of as an organisation. How do we support those colleagues while they transition from training to consultants, as an example? And in that process, maybe stopping or pausing, and the impact of that on other people that we have to bring in to fit that gap. And there are resource implications there. Finance will be impacted. Staff and colleague welfare will be impacted. We may see an increase in sickness absence because that's a reflection of what's happening to them within their personal lives. And those who don't manage to receive a reduction in their training hours because they have to apply for that. So I think there's a wider question to be had, perhaps with our deanery, to say how much information can you give us in a timely way so that we can plan accordingly of the impact and the risk to our organisation, and the risk is how we provide adequate, appropriate, high quality patient care, which is safe. So there are a number of implications that emerge when we come to that very point, and I would like that to be followed up, please. Thank you very much indeed. So in terms of the people in education report from Aziz, can we note the recommendations?
Yes.
Sorry, Chair.
You did. Sorry. Okay. Please.
It was just to give the board assurances. I've actually had a meeting with the lead employer, and it's something I have escalated and picked up. So to help us, Rafiq, on the question you just asked him, the issue I think predominantly is that the deanery itself seeks to be as flexible and supportive as it can be with trainees, and unlike other deaneries across the country, doesn't put a cut-off on requests for less than full-time training. It is something the lead employer is escalating and seeking to get a better working process with the deanery for. And obviously, given they are the employer of all trainees in the North West, they have the sort of speak buying power to hopefully be able to impact that. For example, having come from the West Midlands, there was a cut-off and therefore you didn't have the late last minute notice. But we have to balance that, as you say, with trainees' own needs, obligations and desire to work less than full time.
Yes, thank you for that clarification. So Miriam.
I kind of turned it off because I was probably going to make the same point. This kind of the bit that's come to mind is we see the same in our world around flexible working, with people looking to work differently and flexibly. And I just wondered whether there's a policy or we're working with guidelines or standards. But it sounds like you have some experience of that from the West Midlands. That it's something that we need to think about. What are guideline standards that people have to work to with flexible working? But we have similar things in terms of how to work going forward.
Did you want me to respond? Please. So it's probably we as an organisation, Myriad, have done a huge amount of work on improving our approach to flexible working, improving our guidelines. We have to remember that our trainees are not our employees, so they're subject to the policies and processes of the lead employer. Again, the lead employer does do a lot of work around flexible working, so it's not to say that they don't have similar processes. The issue is the timing and the cut-off for the request for trainees, because it can come quite close to the change of house.
No, understood. I was reflecting on we have these weeks apprentices and things like that as well. So I think working with them to understand what the policies are and how we can connect.
So thank you, Marianne. Heather, please.
Sorry.
You're just testing me, aren't you?
Serial offender.
So can we move back then? You did say you agreed that we could note all the recommendations. I probably had to do that. We move then to matters presentation, the medical information validation reports.
Thank you, Chair. So this is our annual medical information revalidation report. As a reminder, we need to submit a return to NHS England annually describing our upgrades and providing assurance around the metrics that they expect of us. So you have the reports in front of you with a description of where we are in terms of appraisal revalidation. And one of the things that I think is worth just noting and discussing, getting feedback from colleagues is there is no requirement for this report to be really come tax board. It needs to come through policy or organisation governance and signed off by organisational chief executive or the organisational chairman. So it's just a question to the board as to whether we want to continue bringing it here or whether it sits in tech and other functions. There's a number of recommendations that have come out of the return, and to clarify, those are recommendations that we are making in terms of the actions we will take over the following 12 months, in terms of how we want to further progress our appraisal and validation function. A couple of them are just worth maybe making brief comments on. As part of our job planning cycle, we are working to ensure that we have the right number of appraisers. Our ratio is reasonable. We have one appraisal here, 4.6 appraisees, but we can probably do increasing that number and a little bit more, so that we have a resilient appraisal function. There is some discussion about what we do with the responsible officer function in terms of additional support. I'm in discussions with our current responsible officer and the chief medical officer as to how we reshape that, and we'll be back to the board with some recommendations shortly. And it's worth being aware of the pending changes from a physician associate and anesthetic associate perspective, like medical associate professionals, and the fact that they are going to be regulated. This will require that they have that they get captured into our appraisal function with that other requirements with that. So we're preparing for those changes. We have a multi-source feedback policy which requires updating, and that's in the midst of discussion with our local negotiating committee, and hopefully it won't be too long. And I just want to draw your attention to an action from last year related to peer review, which was one of the recommendations, which hasn't been completed and continues to be in action for this coming year. The reason I raised it is that's not really within our gift to execute. That's something that needs to be organised by a high-level RO, and so just to make the board aware that that isn't a shortcoming from the validation and appraisal team. And I'll pause there and say.
Jude, please.
Yeah, thanks. I think you might have answered it, Rafi, but given we've got outstanding actions from last year and we've got more actions for this year, there's no action plan that's associated with this. So I think to your first point, I don't know where the medical council reports to, but I wonder whether it's worthwhile in people committee they just see a quarterly update against the action plan to ensure that we've got a line of sight to we're making the improvements that we need to.
Yeah, happy to
think about that.
To bring an action plan. Yeah.
Yeah, no, I absolutely agree with that. Like I said, there is a role for the board to have oversight on the basis of what you said is missing, and particularly on the capacity constraints around appraisal. Then have further implications for the organisation. Thank you for that. Jeff, please.
I agree with that proposition that this is dealt with by people in the education committee rather than come to the full board. That said, can I just check? When we refer to multi-source feedback, does that apply? I don't know that's in negotiation at the moment, but does that process apply to the 5-yearly process of revalidation, or is it the annual appraisal last? And would that equate to what I would know as 360-year appraisal, thinking of the recommendations we would be?
Yeah, thank you, Jeff. So as part of the revalidation cycle, which happens every 5 years, there's a requirement for a minimum of one set of multi-source feedback from colleagues and from patients. So that's what this refers to. We have an existing policy, an update of that policy, which we're discussing and negotiating with our local negotiating committee colleagues. It does link to some of the discussions, obviously, that we have had within the green oversight group, and ensuring that we have a robust process there. in reality, there are further things that we could do, which, if you like, are just tricky to negotiate with our local negotiating committee in terms of establishing further safeguards or tighter safeguards in terms of how we select the people who are giving feedback.
Okay, I can imagine the sensitivity of negotiation. Nevertheless, I think Green was very specific in recommending that the trust consider undertaking regular as we have here appraisals on each of teams of specialties like spinal surgery, including 362 appraisals. So I'll just urge us to make sure that we can go ahead on responding to that recommendation when we have our negotiations.
Yeah, we're absolutely focused on that.
Absolutely right, make the line with the breathing words. To talk about these things in isolation. Chris, please.
Ricky, I'm in danger of being a bit geeky about this, which is not a process that I particularly think has achieved what it set out to achieve in terms of the national policy. Nevertheless, I think it's worth checking what the actual required accountability of the RO is in terms of it was intended to have an independence of the board, and I just think it's worth having another look to make sure that that process, which I think is fine, also has some route directly for the RO into the board, not necessarily reporting or using the report, but I just think it's worth having another look at that, what the requirement is there, because I think, you know, the RO is supposed to have this independence, not be bound up in whatever medical planning requirements there are. So no big deal, but just worth having a look at. Second thing is the deferral rate is around 10%. Does that benchmark coming out? That strikes me as quite high. So maybe there are particular circumstances, but I just wondered whether that was the explored in more detail.
Thank you.
It's about 60 out of 600 recommendation.
Yeah, so it is a little bit high. We haven't done sort of extensive benchmarking, so I can't confidently say how that benchmark with other organisations. I am aware of some of the reasons. So we are quite strict here in terms of if things are not quite right from an appraisal perspective, then we will recommend a referral rather than sort of waiting. So I'm confident that the process will come back with maybe a little bit of elaboration in terms of the numbers and how we would benchmark them against another organisation. On the point, the previous point, I guess the one thing I'd like to clarify, take a point, understand it and agree with it. I just want to clarify whether you are linking this to the question related to the report coming to board or not, versus do we want to see the RO in board for this report or I just want to make sure that I've understood that sort of point of question.
I'm really just saying this. I think that as I remember and understood the way that the RO role was set up, it had this independence to it, so that it could make independent judgment on fitness to continued fitness to practice or revalidation of practitioners, which was a bit outside the normal medical governance situation. So somehow or other, I think reporting mechanism fine, but somehow or other, I think the RO needs to have the ability to raise issues with the board if necessary.
Yeah, so the RO does. The RO has regular contact with the appropriate net. So that's for us, Carmen Drinkwater, and with her team and myself, bringing that together and always has that contact. I think traditionally the RO function has been part of the medical director's portfolio, but as organisations have grown, just not become a practical thing. And so, if you like, it sits as part of the wider medical leadership with an independent link into the GS.
Absolutely. But I think I won't labour it.
No. Can I just? So I agree with what Chris is saying, because whilst we had at the board delegated responsibility looking at action plan to the people committee, that's absolutely fine. It had to come back to the board, because as part of our own governance process, we need to have oversight of that final document, because the GMC has its role to play, which you know, we understand what that is, but we also have a governance and an assurance role to play in making sure that what we see in the paper from the SRO, is in our line of sight, and any issues which are outliers or offline in terms of where we should be, we need to be noted about, and that should either be a confirmation that everything is going well, or there's a risk associated with what we are hearing, and we can't have that completeness unless it comes back to the board. Please repeat.
Yeah, I will. Thank you.
Thank you very much. So again, for this report, can we note all of the recommendations? There are two.
Great.
Thank you. Great. Moving then on to agenda item 10.3, maternity medical culture. Repeat.
Thank you, Chair. So colleagues will be aware of the history, recent history with challenges in maternity space. Part of that was potential challenges in the dynamic, intra-team dynamic within maternity and specifically the obstetric team. To try and support with that, we had commissioned a report. When I say we, as an organisation, this was led by the then Chief Officer at Oldham and the Chief People Officer by an organisation psychologist to assess where we were, hear from the team, and come out with recommendations. And this is the process that we described. The outcome from that is described in the paper in terms of identifying the 9 areas of potential improvement and themes that came out of those interviews. And the action plan is attached. And there's a description of sort of where we are with the action plan. And in terms of transparency, we decided that this was appropriate for us to bring to board for any discussion, just for us to receive feedback on it and any comments in terms of the progress made so far. I think I'll participate in it.
Thank you very much for being. Chris, your hand is up, I think.
Sorry.
Is it Owen? Thank you.
Yeah, I think refers to in the action plan 5A and the assessment of training experience. I think I would like, in addition to reliance on what the the GMC survey says, I think I'd like a specific bit of qualitative work done with those colleagues to kind of complement our understanding. I don't want to just rely on the GMC survey for that.
Happy with that, Owen, and I can see a route to ensure that we do that.
Yeah, and I mean professionally qualitative as well. Yeah. Yeah.
Thank you, Owen. Jude, please.
Repeat, there's about half a dozen of the actions that are due to close at the end of this month. So first question is, how confident are we that they will all close? And then the second question is, how do we know how effective this action plan will be? So, you know, we've kind of had some feedback, we've pulled some things together. Is there an intention to rerun something when all the actions are closed?
Thank you. So, varying degrees of confidence depending on which points, and the agreement was we will bring that back to the Integration Committee for further sort of oversight. So we're happy for that to be the monitoring mechanism. We will continue down that road. There wasn't an intention to repeat a similar exercise, but what we are having discussions about is how do we ensure that we just have a temperature check in terms of the ongoing improvements and what indications that we have, in addition to our standard markers of what does the staff survey tell us, what does the GFC survey tell us, and what do we are hearing from them.
Thank you. Heather, please.
Thank you. Thanks, Rafiq. So my point is, it might be a point of clarity or accuracy, really. So it's the paper, the report is labelled the maternity culture report, which I recognise, and your framing of it, I understand it. It's the in parentheses medical workforce, because I think that actually gives breathes oxygen into the fact that this is one professional grouping's problem. And it is the interdisciplinary dynamic which is an issue. I accept the framing that there's more attention perhaps to be done with one particular workforce, but it is absolutely a relational issue. And I think it might seem a minor point, but labelling this or framing this as a medical workforce issue, we might be missing a trick about the relational element of this. And just to expand on Jude's question about the plan itself, it might therefore be helpful to have some interdependencies with the larger maternity improvement programme, which you have done in the paper. But the actions related to midwifery workforce issues, there are some separate action plans and work going on that this plan in its totality, it might be helpful to link them more overtly to that work happening. But my point is really to label this as a medical workforce issue. I think it's might not be entirely.
Thanks, Heather. So completely agree with the need for us to implement this with a wider maternity. And I think there is maybe more to be done to articulate how those linkages work and make sure we capture that. The reason it is labelled in that way is because if you recall, in that period, there was lots of discussion specifically about challenges within obstetrics and with the interface between obstetric teams and midwifery and wider team. And so this was the nature of the piece of work that was done. The nature of the piece of work was to focus on understanding the intra-team dynamics with obstetric and some of the linkages with midwifery and hence the label. So it was a very specific work relating to that. Maybe some of the labelling can be reframed to ensure that we are making it clear that there are wider multidisciplinary issues that we need to look at. But that piece of work was a pretty distinct and focused piece.
Well, so therefore, to conform with the label, maybe we need to address some of the actions which refer to midwives. There's some actions about midwives in this plan, and it's labelled maternity, an obstetric or medical workforce. And I hope I'm not labouring a very minor point, but I don't think I am, because I know that some of the outputs of that review were multidisciplinary.
Yep.
They went out as teams, and they do. It is something that they're working on, the relational aspect. So I'm kind of maybe offering to work with you to delineate: is this a medical workforce plan? Is this a multidisciplinary plan? And the plan itself is conforming to what the context is.
Yeah, very happy to do that work. I think probably how I would frame it is a that was medically biased, if you like, because of the challenges that we were looking at. It's a multidisciplinary plan to resolve those issues.
It's a very good way of. Remember what you said.
I need to make the plan conform to what you just said. It doesn't, in my opinion.
Thank you. Tim, please.
Yeah, I suppose it's another linkage point, really. I mean, this report kind of telling us it's a psychologically unsafe space. There's stress and anxiety. There are clinical incidents not treated consistently. It's detached from the experience of women who use our service. So I'd kind of be interested, the linkage to outcomes experience for women who use the service, kind of that should be, all of this must impact significantly on that experience. So understanding the improvement both sides would.
So we have that challenge again about alignment and making sure that all of our places and the environment itself needs to heal and be responsive to all the programs.
And if I may add, Chair, I think it's just important also for us to remember this piece of work was done just over a year ago, and I think that would reflect some of the absence of where we were on our maternity journey. And then I would say with reasonable confidence that a lot of those things have shifted, and we need to capture that and ensure that we're seeing the evidence.
Yeah, please.
Yeah, that's yeah. I must admit, I left feeling a bit clear now, as a result of this conversation about how this is framed, and at the risk of being overly blunt, as I understand it, there's not usually a relation issue between the benefits of subjects and the service. Is that issue being addressed by this or some other piece of work? And when will know whether it's being successful?
Thank you. I'd say it's being addressed by both. So there's this action plan and there's the wider maternity improvement work, which we as a board have been seeing sort of on a monthly basis. And I think the part of the point that Heather is raising is clear, is we just need to be a little bit more explicit about the linkage between both, so there is no confusion. There may be unrelated parallel work streams. So I would genuinely see this as a sub work stream piece of work under maternity improvements. It shouldn't be seen as distinct.
That's why the alignment is important. Thank you, Jen. Chris, please.
So I won't labour the point about multidisciplinary bits anymore, because we've all said our bits of that. But I think the bit about training experience, I mean, very often whoever's in charge of the training programme has got a very good idea about why the reputation of the old veteran service is as it is for training. It is known, isn't it? It is known. It has a reputation. So is it intended to bring the training programme people into this, or just the? It's almost like other trainees elsewhere, as opposed to the trainees who are here, who probably have the most rich information about the service here, why they don't want to come.
Yeah, so the short answer to that is yes.
Okay.
It is in parallel. So we know a reasonable amount of about how training here is perceived through some of the work that we've already done with the deaneries, etc. And that predates some of this work. We already knew that we had a problem. We were sort of flagging red from a trainee survey perspective. We have a reasonable understanding as to why. We're seeing some of those indicators improve, and that links to the point that Owen made earlier about, we're seeing some improvements in GM survey, but can we have a bit of additional assurance? And
you've got that covered, you've got the board.
Thank you, Chris. Thank you, Ricky. Joe, please.
Thank you, Chair. The debate here actually refers us back to a point that was raised at the last board meeting by Miriam, I believe it was, who highlighted an issue of occasionally we look at red, amber, green ratings on pieces of work that relate to the service. And then we also look at a programme assurance report later, and the ratings might not be aligned. And as it happens, I've written before coming today, having read the papers, 10.3 maternity culture, example of different ratings, the assurance rate. And the reason is that this piece of work isn't in that programme. I know from the meeting with the assurance team yesterday, that programme is green rated across the piece, but it's rating only those things that it's addressing. And so when we make these linkages, which is entirely sensible from what Peter's just said, do need to do that through a change control process. So we take that to the change portfolio board, it becomes approved and accepted into that programme, and then we make sure all the governance is lined up. And we've come across this in the last couple of days. Actually, I've been having a lot of meetings around the clinical service excellence programmes, and this has been one of the issues we've uncovered, that over time, a programme gets up and running, temptation is then as problems arise to tip them into the programme scope. One of the issues is it becomes quite unwieldy, in fact unmanageable. And the other challenge is that we lose the audit trail of what we said we were going to track in the first place, because we've now added, rather like a Christmas tree, lots of baubles and lights onto it. So I just wanted to take the opportunity to use that example to point out the process control that we're going to need to keep an eye on. Thank you.
That's really well said, and thank you, Miriam. You see, positive feedback that we are beginning to develop are thinking differently. And the assurance is key, isn't it? But also population what we see with the data that's timely and relevant. So I look forward to further reiteration as we go forward. Thank you. So colleagues, once again, I think we've completed the discussion here. Can we move to noting and accepting the recommendations under medical culture? Can I suggest at this point we have a break, please? So 25 to or nearly 25 to, do they come back at quarter to? So colleagues are joining us online. We're going to break until 12. And number 11 is the research and innovation report. And I believe that Lorna is going to present that in the absence.
Yes, I am. Thank you very much. So I will take the report as fully read, but I do want to elaborate a bit on the alert within the paper. So our clinical coding team is about 70 full-time equivalents. It operates across both of our locations, primarily based out of Salford and Oldham. We had a good discussion in the R&I committee about the real challenges that we are seeing in terms of retention and recruitment of clinical coders. To put that into context, it takes at least 3 years to be a fully qualified coder. Regardless of which NHS provider trust you join nationwide, you start at band 3 and essentially through that training uplift to a band 5 and have to pass some very rigorous exams and tests to validate and accredit your capabilities. And that is a national requirement across the piece. The challenge that we are seeing is not limited to the Northern Care Alliance, nor is it limited to Greater Manchester. We are now being directly hampered by our digital limitations. We have a heavy reliance on paper in our system. We have a heavy reliance on our coders to be physically in an office to be able to use coding books. They are very large encyclopedic type things. And we are seeing increased challenges and a reducing pool of workforce across the nation. That means everybody's fishing in exactly the same pond. It also means that richer provider trusts and many of our colleague trusts in the South in particular are able to offer a much better retention and attraction opportunity that allows somebody to work 100% from home. So higher salary, higher ability to work from home and more flexibility. At a system level in GM, we are therefore starting to lose and erode that workforce. The trainees that we are bringing through, we have been successful in bringing trainees through, are being targeted and offered further opportunities. We've already picked this up now with the assistant of Gertie. We are going to talk and look at what we need to do with the GM system. The risk is anybody that puts a further uplift into a retention allowance essentially places another trust who maybe can't afford that at a greater inconvenience. So we cause an own goal, but it is a nationwide issue now. The impact for us is about our elective activity. So our elective activity is coded. It generates income and revenue for us as a provider trust. We have seen delays to our submissions recently that therefore directly impact our cash flow opportunity. And we have limited opportunities. We are still currently using agency staff in that particular area to plug some vacancy gaps. But we are starting to see a higher level of attrition starting to come through. So it is a wider challenge than just the Northern Care Alliance, hence the reason for the conversation in R&I. I'll take the rest of the report as read. Thank you.
Thank you very much, Lorna. So, Jude.
Yeah, thank you. I just, as I sort of read the AAA, it's probably not question for Lorna actually, but maybe Jane, she's not here. As I read the AAA, it reads like the Digital Risk and Strategy Committee. It doesn't read like the Research and Innovation Committee because there's no reference to our research strategy and where we are against the research strategy or what innovations we're pursuing, and other than the estate for research. So it's a quarterly committee. We have got a research strategy and this should be the committee that's driving the delivery of that strategy. So it just left me a bit concerned about the terms of reference for the committee and its work plan, agenda and repeat. I mean, I'm assuming you sit on it, but it's where is the research and where is the innovation in it?
Thank you, Jim. Which way are you, Lorna?
So absolutely, you're right. We do not meet every month. We have a very detailed work plan. Within that already, Rafiq has brought the research and innovation strategy to that. It is actually scheduled for the next meeting of R&I committee to have a formal update on that, so that would flow through the AAA report. But we are already talking about revisiting the terms of reference, revisiting what the focus, and absolutely within R&I recently we've seen an expansion of the focus of the collateral that we're looking at and the topics we're discussing. So we are planning to do a bit of a review, and we're also with Carmen talking about, are we meeting often enough for the scale of papers that are starting to come through, and are we starting to bring these through? There is no doubt in our work plan, given we have a limited number of meetings, we focus on particular areas at a different time. But you're right, we need to bring further strength to that research and innovation piece, and we have recognised that in the meeting, and we probably should have pulled that through our AAA, so we can pick that back up with Carmen and for the next meeting.
Thank you, Lorna. Thank you for the question, Judy. So again, it reminds us that we need to keep alert to we're meeting the terms of reference, and terms of reference are absolutely inclusive to what we then see in the AAA reports, and that's because R&I, Research and Innovation, is a delegated subcommittee of the board. So that again goes back to the alignment. And it feeds in nicely into what I said earlier on in the meeting, that we will be looking at how we will further strengthen all aspects of the work we do in terms of governance. So thank you for that, very helpful. Craig, please.
Yeah, I just wanted to highlight, my concern for the point that Lorna's alluded to, because there is an inextricably linked, impact on the finance of any trust that's affected by this. And I don't know if Gertie can add anything to this, but I believe this is like you say, it's a national issue. It's something that we should link in with NHS England on, and there is a kind of a medium-term action that we've all got to get to there, because it's not going to happen in the short term, but we've got to get the short-term actions done to start addressing this issue nationally, because you're right, there's a bidding war if we're not too careful with this, because any CFO would pay that extra and top up that salary to get the return that would achieve, and we will end up into some monumental salaries for these. Having said that, I understand that the salaries are not really aligned to the skill sets that's required, and they do seem relatively underpaid for what skill sets required on some of these, and that's from our Alex Garbutt, our digital rig. But what are some mitigations in the short term? I think unfortunately we are hampered by, because I've talked to Alex about how we can access patient records and use AI. We talked about AI abilities to try and mitigate some of this. But as Lorna said, we've not got consistent electronic access to our records across in the way we want to, or a robust way. So I do think, no solutions, but I think some actions to take forward to NHS England, not least of which GM as a regional issue, so we can talk to our counterparts in the patch and understand how we can be more resilient across this particular workforce. But also, work with the digital team, as I'm sure Lorna's doing, around any short-term mitigations we might have to invest in for the future, because this is multi-millions pounds worth of income that we potentially could miss if we get a weaker kind of resilience in this area.
Thank you, Craig, for that. Lorna?
I just want to clarify. So bandings for clinical coders are benchmarked across the country. We are not outliers in the banding that we operate in. By what maybe some of our team might like to suggest, we have seen some practice where other areas are stepping into bidding war opportunities and uplifting those bandings to generate interest to attract people. That for us is the wrong strategy. That will just create movement of staff around our region, and essentially the richest trust will win. And that's not the game we should be in at all as an organisation or as a system. Where we are seeing losses to the south is that London waiting is being paid on top of the current same banding, and therefore that becomes very attractive, particularly when you do not need to move. So if I can stay in Bury and work remotely on a London weighted role, Why would I not do that right now? So that's some of the challenges. So I think we are using agency. We will continue to use agency. We will protect income, but we need to address this at a system level in terms of how do all of our providers work together and what's the opportunity? How do we pool our resources to think about consistency so we don't just see people moving across car parks? And then we need to definitely think about what we do at a national level in terms of what lobbying needs to be brought collectively through our ICB colleagues. So it's not a problem that is a quick fix at all. Agency right now is a route that keeps us moving, but it is a developing problem. And as other trusts are modernising their electronic patient records, they are recruiting more coders. So they are drawing on that playing pool. That's why it's now starting to exacerbate.
I recognise all of those points that you make, and they are extremely important. And I think there's something for us to do immediately as what is our workforce plan, for example? What does that look like? I don't think we're compromised just on coders. There's probably other areas of expertise that we are dependent on, and there are risks associated with, not just financial, but also patient care. So this kind of learning needs to be extended more globally. We're also looking at the town station. I think the pinch points are the ICB and also nationally, because we're not alone in having this conversation. So there are allies to be had here, and influence to make, and that's definitely the route we need to consider doing, most certainly. I think that's right. Thank you, Lord. Miriam, please.
Yeah, mine was more an opportunity to explore, and I don't know if this has been done, because from what I'm hearing, we're looking at the same pool that other NHS trusts are looking at, and creates a problem. But I don't know whether we've explored looking outside the NHS, because I think these skills do exist elsewhere in industry. They don't have NHS experience, and of course I appreciate that, but actually they will have some of these experiences, and we can use that to build pipelines. And I share that because actually across industry, we're seeing a lot of offshoring of some of these skills. So companies are sending them offshore outside the UK, which means there's going to be more supply in the UK of these skills. They are not NHS, but the skills are there. So maybe that's an opportunity for the NHS or for NCA to look outside of, we'll need to build it, but we can use it to build the pipeline. And I think, going into next year, there's potential quite a lot of supply coming up because a lot of big companies are showing skills.
Right,
and I think for them it makes sense because their jobs are global. They can put it somewhere. The skills exist elsewhere. Whereas with the NHS, what you're saying is that you want people here. I think there will be quite a lot more supply in the UK.
The training that the team recruit generally don't come from NHS already. The challenge is the loss of your band 5s that have had 3 years training. If it takes 3 years to be fully qualified and to be trained, then you need to recruit to that level of capability who have actually passed the accreditations for us to be able to certify our coding standards. So there's a mix of how we try and bring in new fresh talent as well as preserving the skill set that we have. But you're right that we have to explore further.
This is the Leadership Academy potential opportunity here, because we could think about a national training programme for coders, and then we could build up that pipeline to come in fully trained and resourced. Just other options. Now we need to move to Tim, please. Tim.
Yeah, I mean, it's linked a bit to what Jude was saying on looking at what's in the AAA report. And the one that I kind of was interested in was the third one on Assure, which is around the NCA clinical strategy. Now, I've got no problem with it going to R&I, but that's such an important strategy. I was kind of interested. It needs to touch all our committees, the board and the board itself, because it drives everything. Us feeding into that upstream, I think, is really, really important. So happy it's there as an update, but kind of curious about where else it is in our oversight.
So that's the one. That's where the explorations that will be part of our whole strengthening our governance and oversight share. Thank you, Tim. Chris, please.
Thanks. On the subject of research, I guess I was expecting in this report to see what you described, but also, there are a number of things taking place in the academic environment of Greater Manchester at the moment, aren't there? Universities seem to point to the accreditation of academic health science centres comes to an end. The CRN is changing to a regional wide approach and so on. So the number of things in this where we as the NCA are partners in these things. And I guess I was thinking that perhaps as part of the strategy, we'd see something about how we were making sure that we played into that appropriately and we were getting, put it bluntly, our fair share, or we were getting our book bang for our buck out of that, because we contribute financially to some of these things. And if we formed a view on this or how that was being handled, I'm looking at you, because I suspect it comes through you, but just generally that was the sort of thing I was hoping that we might, as to report, I might see, and that is the subject of discussion in the future meeting.
Yeah, thank you. All of those things are things that we are involved in. I think Lorna's description of the challenge of the frequency and the content of the agendas just means that the reporting is potentially a little bit stuttery. The things that are featured in this committee's Triple A report are slanted away from the research, and that might also reflect the fact that I wasn't in attendance because I was away for this particular committee as well. But all of those things are things that are captured in the research space and discussed.
Okay, so I mean, I guess for me, there's a sort of almost a time critical element to some of the opportunities for almost trust like that at this moment, where we need to be taking those opportunities. And I guess you need to just make sure they fit into the timescale that you're talking about with the committee.
And it would also be really good to be based on the innovations, because innovations are about improving how we provide care, how we design care, but also the efficiencies related then to, because the smarter we are, then we actually don't spend as much, but we are effective in that delivery of care. And there's lots of opportunities for R&I, and I'm hearing very clearly that we do need to reconsider whether it does meet monthly based on the conversation here, but definitely it needs more in-depth conversation. Lorna, please.
I think we are missing a consideration here that if you look across all of our committee and you look at the conversations and the AAAs and the updates that we are giving, we are driving innovation in each of the fields. To think that we limit that to an R&I committee and innovation goes through a single committee with a subset of governance, I think misses our cost improvement initiatives, our FSP initiatives, our clinical excellence initiatives, and a whole load of other activities that we are doing as an organisation. So I think we shouldn't get swayed by the title of a committee and look to that committee to be the pinnacle and the driver of innovation. We are innovating every day. We are reflecting that in our reports, in the information that is flowing through to board, and we are reflecting that in a number of our other committees and in the programmes in our change portfolio board. I think you're right, there is something we need to do about R&I committee in terms of our terms of reference and the remit and the title, and being really clear that we are cited and we understand what the remit and the role of that is. And we always said when that committee first formed that we needed to bed it in, take some time. And collectively we are talking as a group within that board, thinking about how we really strengthen what its focus is. We've got a very clear research strategy. We do look at that and we see a timetable of that. The frequency of meetings, absolutely we need to revisit. But I think we must make sure to remind ourselves as a board that we are innovating in many different spaces, and that is not necessarily always about technology or always about things and a widget. We are doing that in many of the programmes of change by necessity today, and with some great opportunities and great benefits coming out of it.
So Lorna, you make your point very well. I suppose my point was exactly the latter. So the assumption that I'm making, like innovation, we're looking at innovation, and indeed it is captured and reported in different places. So alignment is again very important. But I think this question for all of us with the subcommittees that we have, that we do need to do the cross check, make sure that that we enable those committees to work effectively. It's down to us, and it's about how we probe and how we assess and how we reframe some of the things that underpins our core delivery against those terms.
Yes.
So thank you. Colleagues, then, I'm here to hear the voice of all of you saying that you accept the recommendation that comes from the research. You talked to me, didn't you? It's fine.
Well, the very briefest point, I just want to build on what Jude mentioned, because it brought immediately to mind for me, and it may have done for Jude, an exemplar of this type of work. And Craig and colleagues took us recently to Leeds to see an exemplar around financial sustainability and CIP. And Jude and I both had the pleasure of working at Alderhay, where the research and innovation was as impressive as I've ever seen in the NHS, and for a relatively small trust. And the links that spawned, build on Chris's point, into academia, and the partnerships and relationships they had with academia. At times you weren't sure whether you were in a hospital or a university. It was that profound. And also, to the point of innovation is happening everywhere. I get that, but I would go back to the very simple rocks, stones, pebbles analogy. Is there are some bits of innovation that are big and need investment and need careful thought, and those would be the elements I think that would be amenable to go into a committee. Notwithstanding the fact that there are myriad innovations happening every day at NCA, it's those big things that sometimes need a sponsorship and a push and an analytical frame to get them off the ground. So I would just advocate looking at an exemplar trust in this regard. And it might generate some ideas.
Yeah, no, it's a very good idea. And again, it brings back the context of NCA being an education and training place. So we have research activity because the trainings that come in have a competence to meet around audits and also research. So it's a very accessible access point for us to enhance and improve our services. But there's a combination of all the different complexities that we just need to consider more carefully, and how best we report them and how best we engage them and align them, the operational performance and also financial effect. Thank you for that. I still need you to confirm that you have noted the recommendation. Thank you very much, Laura. Thank you. Annual planning.
Excuse me.
Oh, sorry.
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 If I may speak for just a moment, I agree with all of what's been said, actually, and looking at the R&I committee, there is most definitely a leaning in the committee towards clinical research, digital data, and I envisage AI being a part of that, an increasing part of that in the future. I think we probably need to look at the structure of the AAA reports, because actually the ethos of those is that we are raising concerns and advisory points, and actually if our progress in line with research is in line with expectation and plans, they wouldn't necessarily then feature on that AAA report. We did have an action at not the last R&I committee but the previous one, where we did want to see a quarterly update on progress around innovation. We obviously do get to see and approve allocation of funding as part of the committee, but I think some of this is probably just what's then appearing on the report, and the nature of what is getting raised to yourselves on the wider board. Thank you.
Thank you, Rachel. I don't think anyone needs to be, particularly colleagues who sit in our life, defensive. This is a work in progress, and we're just trying to strengthen the way in which we receive governance with your delegated committee. I know the points that you made, but it's something that we all need to consider collectively and reflect upon, and can try that understanding to how we then feature the elements that we need to see in the AAA report. So I think when we are there, the AAA report is right. It's just how we display it. And that's going to be a reflection of terms of reference, and there will be a review. So thank you. Colleagues, we then move to the annual plan, which is agenda item 12 and Jude.
Yeah, thank you. I'll take it as read. Two things just to pull out. There are two red rated objectives in this. One is about our theatre improvements, and just to talk about actions that we're going to take as a result of that. We've got a GERD review that takes place next week, so there's been quite a bit of planning gone into that. They're going to focus in social care organisations, probably the ones struggling the most. We understand some of the limitations around theatre improvements only because of the estate and the issues with RAC, that we only have half a recovery unit. That limits us significantly. And we've got some actions in train around Rochdale Infirmary, but we wanted to focus that here. The second red rated is in relation to our nursing accreditation scheme and where our ambitions were in terms of green rated wards. And Heather has got some actions in train in relation to that and some additional resource to start to look at those wards that are off track or red and amber rated, to look at what more we need to put into those wards in terms of support to get them improving. I think the question for the board overall through this committee really, and the discussion today, is as our board subcommittees and the chairs of those subcommittees sitting around this table, how confident are you that your agendas are driving the delivery of these objectives, and you have a line of sight to where they are, and the papers that we're seeing and coming through are talking to the delivery of these objectives. And then my second question really is, are there other areas of focus that we need to pay a little bit more attention to collectively through those committees and through the work that the executives do in the organisation to further drive the delivery of this plan? So I think a couple of questions.
Thank you, Jude. Questions, please? Nobody. I think there is nobody going to respond to this question. She asked very nicely. It's an important question because it goes back to what our purpose is, what we're meant to do in these committees. Aziz.
I think it's something to take away, isn't it? We're going to have our chair subcommittee, and that needs to go on. That could go on the list, Jane, of all the things that we discussed. Because I mean, there's various things that I just mentioned earlier about, the mandatory training. Where does it go? We don't need to discuss it twice. It's the third time I've discussed it now in a month.
Thank you, Aziz. Lorna.
I think it's something for me about our ambition around population health and that direct linkage to the initiatives we're doing at the moment to address core and foundational deliverables, the initiatives to address waiting list demand and all the operational demands that we see, and that longer term strategy piece that we keep reminding ourselves that we need electronic patient record, we need a core set of digital footprints to be able to really make seismic shifts in population health. And yet we've got it embedded within our objectives, and we are talking about the development of a data strategy and using AI. But it will only ever be as good as the qualitative the data that we can actually surface, and we know that's a challenge. I think there's something for me about revisiting the reality of how far we think we can travel and how we better reflect that in here and where we do that at a committee level and at a board level.
Yeah, agreed. It's an appropriate challenge to all of us. We share the community. For example, in our community, cancer pathways, we know that we are tracking the reason why. Do we line that to and on that object? The diversity and inclusion population health progress is notable, but that's the only one. It's easier to quantify than the others. So I think there's an absolute need for us to reflect on what you just said, but also begin to have those conversations and make those alignments. Otherwise, we have an opportunity to have clear line of sight in a good timeline where we can have a further conversation, which means we are concerned we're not going to meet our annual plan objectives, we're going to be on track. And did we know that actually what we had reported, what we had identified as a timeline is unrealistic now, and that needs to change, and the risk associated with it also needs to change. Are there any further comments or questions? Craig?
Yeah, Sue's not here just to represent some views that Sue and I have discussed complex finance committee, but a wider context as well. I think we acknowledge that we continue to improve. We do need to continue to improve around the alignment of our BAF and our risks to our committees and what we're trying to address, and subsequent actions that those committees take to address those risks. 12 months ago, we took note from a PwC report that described a different, more interactive methodology, the 3 lines of defence type methodology. We've gone through some of that with the financial risks, and we've taken it recently through audit committee, and it's received a lot of good feedback. And I think we need to, and Sue as well, represented Sue, if you need to start to really roll that out properly in the organisation, and then have that more clarity of connection to actions the committees are taking to addressing the specifics of the BAF, because those are the risks that those committees are assigned to address. So that was some of the feedback that Sue and I have been discussing.
No, that's really helpful. That's good. Thank you very much. Jeff.
Thanks, Chair. The company's comments I was going to make in relation to the next site of that planning for 25-26, but given the conversation that's just emanated from due to question, personally, I have no great advice on how we can make sure that the organisation is even more focused on these objectives. Frankly, if they're not, then we would have a problem. My question is more along the lines of Lorna's point. When we think about our planning for 25-26, are we making enough of an effort to think more long term and strategically about how, alongside doing all of this, we are very specifically thinking about how to control our demand? And I think we personally could do more than we have done this year in our planning process to emphasise that agenda. A couple of specifics. First of all, the Greater Manchester agenda around collaboration. Someone was on a Greater Manchester non-executive meeting yesterday, wasn't it? And was talking in that meeting about the Integrated Care Board from next year commissioning for integration across a few trusts, rather than waiting for us to do it. The ICB would commission. Now let's see how far that goes, but nevertheless, I'd hope that we would consider those opportunities in our planning process. And then secondly, for me, how we really use our demand by including in our planning processes are 4 locality boards, and maybe using the 4 localities partnership as a mechanism. I don't see the work of that partnership coming through our governance other than to the Research and Innovation Committee. And I personally would really like to see that partnership being reported through the board level. And we have a real understanding at the board level how that partnership is working, what our contribution to it is, and what its contribution to our long-term objectives can be, and how can strengthen that. But also mental health. You think about the impact of, for example, any of mental health abilities. It is enormous. The benefits to us would be enormous if we could support mental health services in all its guises, from treatment to improves of lives, as well as to NHS mental health services, how we could support that, just to help them, so to help us. And finally, community health services for both children and then for adults. Are we doing enough in our annual planning process to really focus on community health services? Just by looking at the paperwork we get here, it feels a bit sort of not quite at the centre of things at the moment. Could we, through our annual planning process, bring it more to the centre, think about what those services could do, partnership with others to help us with our demand going forward?
Yeah. Points are really well made. It kind of challenges us, isn't it, to not just think at provider level.
Yes.
We have to think at system and partnership level. The neighbourhood, particularly in the context of mental health, is really pertinent. So I think there's a wider lens that we can apply for 24-25 going forward to capture what you just said. But there's also something going back to Jude's point earlier on around executives providing the alignments in those committees where our annual plan is not meeting, or has the potential to not meet the not be met because of what they're presenting us with. I mean, I don't know, give access to cancer and other our next activity, all of those sorts of things. So it's a combination of partnership between what's including. Oh, you've been very patient.
Thank you, Chair. Just first of all, thanks to Jude and Jane for pulling this together, because it has been something that has been kind of staged for a bit of time. So, but my question is something that I'd just like a little bit of feedback to myself, Jane and Jude outside of the meeting, just about whether people feel that as a report is value adding. And I'd say that also in the context of a lot of other reports that we receive. I just want to make sure, I mean, the discussion that's been had is actually will indicate that there is value in it, but I'd just like to know that for sure, because it's not a piece of work that just costs, it's quite a lot of work to put it together. So if I could just get that feedback, Chair, that would be helpful.
Yes, would you like that feedback? You're asking for that feedback.
No, I'm asking for that feedback, not onto the agenda and whatever else.
Right. Okay, I think,
I'm asking for that outside the meeting.
Yeah.
Please.
thank you. We'll go back. Did you raise your hand then? No. Jude, would you like to, first of all, can we note the recommendations under budgets 24-25?
Yes, thanks, really. Can I suggest? So I think Susan's made a suggestion about having a conversation in the chair's meeting. I wonder whether there is an action for the objectives that are aligned to each sub-board committee, just to be on the agenda for the next sub-board committees, just to enable, if there is a discussion to be had, as Lorna suggests, about a particular objective, and where we might think that we might not deliver that objective or we need to revise it, we signed this plan off as a board, and I think there's just something about good governance which says, you know what, we've had a conversation about that in the subcommittee, and we've agreed that actually this would be the extent of our ambition this year. We probably had overstretched ourselves. So I think maybe it's just good practice to see them through the sub-board committees again.
Written the email to make that happen. Okay. So I'm reading to your mind.
Yeah, thank you.
Thank you.
That's right. Can we move on then to 25?
Yes, so you'll see that Greater Manchester ICB have brought the planning process forward ahead of what we usually see as our Christmas gift on Christmas Eve, which is the planning guidance that usually lands for all the 25-26 planning. So we've started to do some planning. We're doing it on the basis of a set of assumptions. We know that there has been a budget delivered since those assumptions were agreed in a GM system. So I suspect that while we're thinking about the planning, that we will find ourselves making many more submissions this year, because I think the planning guidance will land, the budget will influence the planning guidance. Our first submission is on Friday. It's a basic yes, no tick box against a set of things. Do you think you're going to deliver them? Yes or no? What do you think people will be? So it is very, very high level at this stage. We will, through our strategy meetings, both pre-Christmas and post-Christmas, have the opportunity, I think, to explore some things that strategically we want to focus on next year. So in December, we're going to have a big conversation about dermatology and strategy across GM. That Jeff will link to some of your points about what happens in community and out of hospital and demand management and some of those things we can pull into that. We're hoping to have some general practitioners come and join us in that conversation to make it more rounded. And then we will step into what we did last year, where we have a board session to really think about the plan, where we've got to in the numbers, if you like, of activity and money and performance targets, but then start to have that conversation about our priority objectives for next year. And I think the starting point is always, where have you got to in the year that you're in? So really the ask of this committee is, we will we're in the middle of it now. We've engaged in the planning process for GM. We will have to make some submissions. Some of those will fall outside of the board timetable. And so we're seeking permission for Craig and Gertie and I to make those submissions and take them through the subcommittees where we can in that timeline. But we'll have to be a bit political, I think, and I suspect because we've gone early, there will be slightly more submissions than we might see normally.
Thank you, June. Jules, can we please have a confirmation of the ask?
Yep.
Sensible, I think pragmatic, absolutely right thing to do. Yes, agreed. Thank you very much, June. And can we for completeness just confirm we have accepted all those recommendations?
Yep.
So we're now on to bid item 13, our change report portfolio board. We're going to first hear the report from Owen, and then we'll take questions, and then we'll move to any questions related to Louise's reports, which follows afterwards. Thank you. Sorry.
Yes, just a slight adjustment. I think Louise will need to present her report as well around it's important for the independence factor that she presents as well. But I just wanted to talk about in terms of 13.1. I think what it's probably worth just focusing on is particularly around the clinical services excellence. And again, I'm assuming that these reports have been read. So in terms of clinical services excellence, which has three sub-elements that relate to outpatient excellence, theatres excellence and urgent emergency care. A bit of a common theme as to why they're alerting, which relates to a combination of risk against delivery against financial plan, and also in the relation to urgent emergency care, there's also the scenario around capacity that features in there as a thought process. So again, as we get through the conversation as Louise presents, there may be the questions that board members want to ask directly of SROs in respect of the individual schemes around that. I'll just also flag as well, I'm not ignoring clinical leadership model, but a bit like last time, I do feel like there is some progress and some movement around that, but there is still work to do as flagged out in the cover sheet. The perennial target operating model, again, that has progressed, although there's just one or two things around fiscal side that we just want to check through. But generally, in terms of some of the challenging aspects of this, which is, for example, people now potentially who've been displaced as a result of the process, now knowing what their next stages are. We're kind of through the lion's share of that as a piece of work, but I think there is just some work financially we just need to do to make sure that we reconcile what our expectations are of the target operating model. There's some work that I know that Gertie and Heather are needing to work through around that. If I just briefly go on to advise, again, communications and financial sustainability plan, I think they're quite self-explanatory. And what you then see is the three things, some things that I've referenced in terms of the clinical excellence service. You get a bit of a description about how we dug a little bit deeper when we had the conversation at change portfolio. I think unfortunately we weren't able to have any non-executive directors in this particular conversation. So again, it's just a thing that it would be helpful if we could have that presence in the meeting, because it's just useful getting that additional lens into the conversation. Probably one element I would just talk a little bit more about is that we focused on was the GM scaling of people services, which is quite an exciting opportunity, I believe. And there's a lot of opportunity for innovation and collective working there. Maybe blends a little bit with Jeff's point about not just looking at things from a sovereign organisation point of view, but what are the broader system opportunities that spread from that. So we had a quite good presentation around some of that. And again, I think that will need some focus. There's a little theme that I've often say about this particular aspect when I think about GM system I think we are moving ever increasingly into a space where when we talk about GM system, we can talk about a general shared direction of travel. But then in terms of the partners who are involved in achieving that direction of travel, I think we're moving from a model where we always say it has to be all of us in agreement to a model of a coalition of the willing, which is going to be an interesting thing to see how that pans out. But I'm just flagging that as a part of it. And I think the GM scaling people services is an example where if you imagine it as a menu, there may be some things that the NCA says it wants to be a part of, with, for example, a Christie or MFT, but there may be some other people who say that's not for us right now. I think we're maturing as a system to be able to move to that space. So I just took the opportunity just to talk about that. I won't talk any further on that. I'll just take any immediate questions that come in relation to that, but just bear in mind, Louise is going to give an assurance piece in a minute.
Are there any comments or questions?
Yeah, Chair, I did have a substantive point to request some action of the board in relation to the clinical leadership model. So I don't know whether it's appropriate to do that now or do it when we get into the assurance report.
Could I suggest we hear the assurance report, or I think it's...
Thank you. Before we go there, can we just accept we have noted your... Thank you. Please.
Thanks, Chair. So if I can introduce the portfolio assurance report under item 13.2 and also just say a few words about some of the work we're doing to address board members' feedback, in particular from non-exec directors, in terms of the broader portfolio assurance piece. So in terms of the portfolio assurance report itself, in terms of slides, I think it's slide 13 of 49, so that includes the graphs again that show the trend of the overall governance and delivery ratings. The total number of programmes in the portfolio still remains at 18, of which 15 were assured. From a governance perspective, we can see from those graphs that we had an increase in the green RAG ratings from 4 to 5 this month. Those are the maternity, medicines management, procurement, community diagnostic centres programmes plus digital month. But also an increase in the red RAG ratings from 2 programmes to 3. So that's clinical leadership model, urgent emergency care, and theatres programme this month. From a delivery perspective, the graph on the right, an increase in the green RAG ratings from 5 to 6 this month. So again, maternity, medicines management, digital, procurement, state facilities, plus digital this month. But also an increase in the red RAG ratings from 3 to 6 this month. So that's clinical leadership model, target operating model, medical workforce, plus this month the 3 clinical service excellence programmes. And just to connect with the AAA reports, any programme with a red RAG rating, either for governance or delivery, is highlighted in that matters to alert section in the AAA report. So direct attention to those areas that might require a little bit more scrutiny. If I can just then summarise a couple of things in terms of the broader work in response to board feedback. So firstly, to respond to questions alighted on particularly in last month's meeting around the kind of the composition and the scope of the portfolio, and also reasons why perhaps the independent portfolio assurance ratings might not always align with other ratings seen through other performance reporting. So we've included an introductory slide in the portfolio assurance report this month. That's slide 2 of 49. And that's to try and articulate a response to that. And also included at slide 5 of 49, a slide for reference, which is the inclusion criteria used by Change Portfolio Board to consider whether a programme is suitable for inclusion in the portfolio. We've also drafted in a bit more detail a paper which has been circulated to non-exec directors, and that will be included on the November Change Portfolio Board agenda, so that'll come through to Board of Directors in January. And then secondly, finally, the piece of work we've been developing to illustrate alignment of the portfolio with strategic objectives, and also a kind of a coherent timeline for the portfolio. That will be presented to November's Change Portfolio Board, and again thereafter into the next board of directors pack in January. We should see that coming through to the next meeting. Thanks.
Thank you very much, Louise. So I know that Rachel has a question. Rachel, I'm going to you first.
Hi, thank you. I've got one for the previous item and one for this item, please. So the first one is around the CLM. I had a deep dive session on Friday last week with Alistair and Peter. We talked about some of the points raised in our board development session a month or so before, and I highlighted, I think, a shared interest that a few of us NEDs have in understanding two aspects, really. So the first one is around the case for change and measurable benefits of the programme. And that actually, I think, as a board, we would benefit from having insight into that, even though the detail of everything else to do with the programme will remain, obviously, where it should be in the change portfolio board. They took that away, but I wanted to note that as an ask that I've set at the feet of Alistair and Peter. We also talked a bit about the approach and the timeline, and actually a very ambitious timeline was obviously previously discussed for the programme. Given the approach that we're taking, which is one of consultation across the organisation and various groups, obviously the team are revisiting that plan and timeline. So again, I think that's an aspect that as a board we may want to have to see the detail on at a subsequent update to the board. So that was the piece on the previous item. Shall I go on to the one to do with the assurance paper, Rabina, or would you like somebody to come in on that?
You did pause then. Will we make a note to repeat that it's one for you to follow up on the point that there's asked? Thank you very much. And I will come back to Joe on the same item. Please continue.
Thank you, Rabina. On the point of the assurance pack, I think the additions that you outlined there, Louise, are useful to understand what would actually warrant moving into this assessment. I think that is a definite useful addition. One of the things I wanted to bring back was the action that I spoke about last board, so 2 months ago, which was around understanding what might have changed since the last report. There is mention of it in the paper that you are looking at that, but I wondered if we could just understand perhaps when we could expect to see that work, please, to understand what's changed between board from one board to another. Thank you. That was everything, Rabina. Thank you.
Thanks. So the individual programme slides show if there's been an upward or downward movement in the pack, but we could look at bringing that forward into the overall dashboard if that would be of use to the board.
Could I just test that? Because when I look at this, I do get the direction of travel from the last meeting. So I'm just, the arrows tell me.
I think Maria brought this up at the last meeting, and I would agree, and I think Rachel's agreeing that those arrows could go into that dashboard, because when I saw the two graphs, it's obvious there's been an increase of 3 there and an increase of 1 there, but you just told us what they were, but it's not obvious until you go. Then you've got this grid which doesn't put the arrows in, and maybe it's just the ones that have gone down we need to know, or the ones that have gone up, not the ones that stayed the same. It'd be easy to put the arrows in those boxes because the arrows come further down, so you have to go through each one, and there's 18 to find out which ones have gone up, which ones have gone down. And as non-execs, our job is triaging stuff and looking at where we've improved, where we've not, and we're having to look through every single one to work out which one of the ones have they gone up or down on. So I think the arrows in the dashboard would really help.
Far be it for us to make your life easy.
Thank you.
It stops us, I think, incorrectly looking at just RAG rating on that report and actually doing a meaningful analysis of what's on that slide. So I just wanted to, raise that again, because again, I do think it would be really helpful having it in one place.
We'll have another look at that, Rachel. Thank you. Joe.
Thank you, Chair. Yeah, colleague might be shocked, maybe horrified to learn that this is my 12th month. It's 1 year today. And I say that because before my arrival, I was talking to colleagues about the clinical leadership model and the kind of rationale for it and where the thinking had come from. And that resides in this room. And this is not a direct response to Rachel, by the way, Rachel, because you know I was about to raise this before. In contrast to the other large programs, so the Financial Sustainability Plan, Maternity, and EPR, which I would get the sense they're all sponsored here, owned here, understood here. And I think the programme team can probably feel that as well. I think on clinical leadership model, I don't get that sense. And the programme team don't get that sense. And now the clinical groups that are all being convened, which is a large number of colleagues and a lot of discretionary effort going in, they don't get that sense either. And so it's a bit of a fault line across the programme. I was chatting to one of Louise's colleagues yesterday, and sorry to interject, I went to the meeting where they assess all the assurance ratings every month. Very impressive. They know these programmes like the back of their hand, and you can put on that assurance that you receive. Anyway, one of them, Tom, I was describing this problem sequence and sounding board advice, and he brought up this word that I'm still getting to grips with, relatable. And he said, it's because the others are relatable, Joe. There's FSP and EPR. And CLM is a bit conceptual. I think we all realise that from the start. What we need to generate together is a touchstone so that we all know what it is and everyone else that we invoke to work on it knows what it is. So the programme, in my head, is being directed from here. This board has asked, through the Change Portfolio Board, a programme team to go away and design, and if approved, potentially deliver the I think that's the government situation. And so I think the degree to which we keep asking the programme team why they're doing what they're doing seems a little bit counterintuitive at this stage after 12 months. The context is that we've had a clinical design group do a lot of work in December, January. All of their work encapsulates the case for change. They understood the case for change. The case for change has also now got into the packs that we've given out to the design groups, so they understand the case for change. But yet, I don't think we around this table are completely aligned that we all understand the case for change. So there's a job to do there for us, I think. On the 1st of May, we brought back some packs around the phasing of the programme to this board, and you agreed that phase 1 could be designed and implemented, which was to do with the corporate support, and you agreed that phase 2 should be designed on the basis of the work that we brought back, as mature as it was at that stage. So that's what's happening. The design group started on the 16th of September, and when they've completed their design work, and I'll touch on timeline in a moment, there's a very rigorous process called a critical design review, which will involve certainly all of the executive directors and a wide range of colleagues to critique and assess those designs to make sure they work. And that's before they come to this board. So there are lots of checks and balances. Allied to that work of design is a lot of detailed work now going on around mobilisation and transition. The first workshops have started on that, and more detailed workshops on defining benefits and the metrics that Rachel alluded to. All benefits need to be measurable in some sense, and that's all part of this design process. So to use the 3 R's to sum up here, which I guess everyone's aware of in the NCS, I think the reality for a lot of people around the programme and in the design groups is they're feeling a lack of conviction and a degree of equivocation and even nervousness outside them and above them. I think the result we want to get to is we need a consistent position, we need unity of purpose, and we need advocacy support for the design process. And so the response that I was going to ask you to consider today was, I think there are 3 fairly modest things we can do as a programme. The first one was to think about the design group chairs meeting this board at the right time, so they can hear your ask of them. They can relate back to you, and it is really interesting. Rafik and I joined, they have a weekly meeting with 5 chairs of the design groups, and we joined them yesterday. And you can appreciate the work they're trying to do and the amount of time that's taking and the challenges they're facing, because it won't surprise you to know that a lot of the colleagues that they're bringing into their design groups also have many questions. The second one is, I think we could usefully, as a programme, produce a memoir. That, because we brought lots of papers, this has been discussed in lots of places, but where's that two sides in my back pocket that said, so we could helpfully do that. And I think also I've drafted yesterday a programme charter for the programme team to consider, because when programmes, in my experience, have got a bit sticky or a bit complex, a charter to what we all commit to, 6 or 8 or 10 points, can be quite a useful touchstone to remind ourselves why we're doing what we're doing. So that's, I think, what the programme can do. What I was going to suggest and request that the board might do is discuss the topic when you get the opportunity again. Agree what the position is, how strong the position is that you want to make, and then reserve judgment, suspend judgment until the design work is complete, because the design work will flow back here, which will be absolutely the appropriate time to have that plurality, is the word I was searching for, or views, when we all interrogate the design and make sure it's fit for purpose. So I hope that maybe resonates. I don't know if you recognise that position at all. And it's just keen to understand any response. Obviously, I would defer to Beaker's SROs and anything that he would want to. Thank you.
Thank you very much. It's very comprehensive, very clear. I'm going to go back to Rachel because she wants to respond, I believe, to Joe. Rachel?
Yeah, thank you, Joe. Support what you said. This is these are the points I made before you spoke. So I think that I would argue on the first intervention that you recommended that the team heard the NEDs at the board learning session. We articulated in that session a concern about lack of firm measurable benefits and an unclear case for change. So I would say we probably don't need to meet the team again. We probably just need a firm action as to when we could expect to see that information. Whether that is some time spent in a future board learning session, but I have recommended, given the criticality and scale of this programme, that the board are kept in the loop on this up until the point where that confidence has been gained, and we can then put that assurance back into the change board. So I support what you've said. I just think we could probably just get to that delivery of the action rather than discussing it again. Yeah, thank you, Robina.
One tiny point of clarity: the people I was suggesting you might meet is the chairs of the design groups. So they're not the programme team. These are consultants, they're directors, and they're new to the programme in the last 6-8 weeks. And they're the ones who are doing the real heavy lifting at the moment. And it was as much for their benefit as for yours that it would be good to maybe have that interaction. Thank you.
I think we should that interaction. I think it's important because we are vague in certain points, and I'm actually concerned that the colleagues who are driving this feel there's a mismatch between what the board are hearing and thinking and understanding what they are delivering on our behalf. I genuinely feel there's a relationship, a clarity of purpose, confirmation that's required in that respect. So I would embrace that. I think it's important to do that. Can I move on then to further comments? Thank you, Joe. And that is, I just see it's Tim, I believe, Tim.
Okay, thanks, Chair. Yeah, it's kind of picking up on that point of, just looking at the clinical service excellent programmes that kind of flip to red on delivery. And it's a bit unclear to kind of follow through why that's the case. So I'm not sure whether it's Jude or whoever on that. It's kind of looking at last month, and if I kind of just look at outpatients, there's an assurance in last month's assurance report. We will be delivering the financial savings. They're just delayed by a month. If you look at this month's assurance report, and again, you've got to dig to find if that disappears, that statement. It's just we haven't met it. Similarly, for Dieter's Excellence, last month, all COs, the assurance is all COs have action plans in place to reduce cancellation. This time it disappears. and the assurance report. It's quite, you've got to kind of, as Lisa said, you've got to dig around to kind of find that. And I think that needs to be more on the face of the report. This is why we've gone into red for delivery. And there is a link back to the commitments and the assurance the portfolio board took last month. Why those assurances have disappeared in this month.
Continuity of the governance, isn't it? Again, can I just check that those colleagues are waiting to ask questions? Are we still on the clinical leadership one? Because I want to complete that too. Yeah, so Lisa, thank you.
Sorry, I
jumped
back to that. Yeah.
Sorry, Chair. Tim, may I ask? The point you just raised. Part of the opportunity here is for you to ask the SRO that question.
Well, I wasn't sure whether it's Jude who talks to that. I'm talking generally to the point around the narrative across months. And it's particularly the narrative on an assurance being given in a preceding month that the Change Portfolio Board would challenge, particularly with regard to we have plans in place, that's our mitigation. But suddenly, no, we've just got cancellations now. There's the missing piece. I suppose I'm talking to the portfolio board itself. It may be Judy who answers. There's a general point and there's two particular points around the excellence programme.
Because if you think about it, if you're asking the Change Portfolio Board, then there feels to me like there is something that is missing there then. If that question is not, for example, going to the SRO, it feels like there is something missing in understanding how this conversation should be taking place. That's why I just made the point.
Do you want me to? I mean, I can't account for what's written because I don't write the words on the page. So Louise can account for what's written and the words on the page. But I think for outpatient excellence as SRO, I'm confident that we'll transact the money. I've had confirmation from finance colleagues that we'll transact the money because you can see that the KPIs are going in the right direction for CSC. So that might be a timing issue about when I've had them assurances from finance colleagues and how we work out how you translate PIFU, but you can see the metrics going in the right direction. For theatres excellence, you can see in the annual plan report, I've rated it red. I think the cancellations are static. There were some improvements actually in Q2. We've lost them as we've entered into the summer months and beyond. And I think that's why we need GERB to come in and look at what more could we, should we, and can we be doing across that programme. One of the key issues in Theatres Excellence is we have no clinical lead. So this is all very much led kind of operationally. So typically what you would see in a GERB programme is that there is a clinical lead for theatres, certainly across the patch. We've been out twice to advert for that post. We have got one applicant as of last week. So we'll progress to interview with that. But we need some clinical leadership alongside, I think, our teams to have those conversations with colleagues. I think there are some control processes in some parts of our care organisations around cancellations. So they've happened without the adherence to the policy, which we've written, which shows some very clear escalation of executive care org director level before patients are cancelled, because sometimes there are things that we can move around and do, particularly if it's staffing sickness on the day. You know, we might be able to move across care organisations to rescue us and stop patients being cancelled. So there's some definitely control mechanisms that need to be in place. But I think fundamentally, if you park the cancellations elements of theatre excellence, there is a real challenge for us, I think, in our planning of the 642 process. And there is a reluctance, I'll say that, I think you might want to say something about taking lists off surgeons that when those lists are not booked at 2 weeks out. So looking down at 2 weeks out and removing the list from the surgeon. So we we work with people and then we're really planning at the last minute. And sometimes that means people are not through their preoperative, not completed their preoperative assessment. And, you know, there might be something that emerges from that with a last minute cancellation. So I think that's what we want Gov to have a proper look at when they come in next week.
No, thank you. That's exactly the sort of answer I was kind of looking for. I think this is a fantastic report. I don't think many boards have this type of report, and inevitably it's going to have some brevity in it, and inevitably, particularly non-execs, we're going to keep asking Louise to add something to it. So I think there is that. So, but it's for here at the board to get that narrative behind a box flipping to red. Thank you.
Well, thank you for raising the question and directly to the SRO responsible that you have the clarity and the assurance that you saw on behalf of the board. Thank you. Aziz.
I wanted to thank Joe for his comments about clinical leadership model, and I agree with his description of perhaps, you know, the board giving mixed messages to the teams that are leading this and how that is damaging to those people, and I regret that. I think that characterization is correct, actually, and I think that we do have a piece of work to do to help us to be more supportive of it. And I mean, you know, it could be a 2-page at the back pocket, and you know, as you said earlier in the year, we were given a timeline, and as with lots of timelines like finance, we looked at it, it looked very ambitious, and we're still on track. 6 months on the finance one, on this, not so. So, you know, we did support it, and we did, but we do need more information about, and you said that those groups have gone off and they've got all the evidence. Well, I haven't seen that, and I think there's probably members of the board who haven't. So I don't want to overlabour this point, but I do think we've got a piece of work to do, because it's wrong for us to be sending mixed messages to people who are implementing huge, difficult change in an organisation. We've got some work to do on that together, I think, between execs and all of that. So let's do it.
Can we just use that example to reset our thinking? Because when we agree things at board, we must own them, and we must be consistent in how we relay those messages to our colleagues who are working very hard. Not just the ones who, not just the design team, but those colleagues they have to bring on board to make that engagement work, and for those further colleagues to invest in this message. So there's something for all of us to be mindful of, that at board meetings, when we are unpacking or discussing or considering, not only do we own that, but we appreciate the values that underpin the behaviour that we then demonstrate outside of this boardroom. If there are things to be had and to be said, it's the safe environment to have those questions and to put forward those challenges. If we don't do that, then we have a problem. So I understand that there's complexity, and I understand sometimes you can leave a board meeting a little bit frustrated. Go back to the executive officer, go back to each other and just talk about it. So we don't have conversations outside of the corridor, because they can unpack and undo all of the hard work that goes into shaping what we ideally want to see, and that is clinical engagement, which impacts on our clinical services, which impacts on our patients who receive that care in a uniform way that we absolutely endorse. And that's why I welcome the 3 Rs and certainly support the 3 responses that you have identified for us. Absolutely, Joe. So thank you for that. Thank you for that, Aziz. May I move on then to the next question, which is from Peak, please.
Thank you. I thought there was one of 18, but I'm happy to go.
We're not need to go. 15.
So when
Yeah, sorry. Go on.
So I think what I'd like to do is say that we shouldn't automatically accept what Joe said is correct, actually. So, you know, it's a view he's given. I think we just got to be careful about saying, okay, that's work. I'll just give you just 3 examples about it, because I think I buy into certainly the group of colleagues who are doing the work and how they might be feeling. But if you were asking me to contrast from 12 months ago, give you 3 examples. A medical director now of a care organisation who now can articulate the concerns that they've got about the impact of the CLM and how it relates to place. To be able to articulate that, that means there must be some understanding about what the CLM is. I think that's a good thing. I'd also give another example of a community nursing colleague, okay, who demonstrated understanding of the CLM and asked the question about, so my understanding then, Owen, is that this is not just a clinically led, medic-led type thing, that actually there's opportunities for me as a community nursing colleague to be in the leadership architecture of the clinical leadership model. And the third example I gave was a session that I think June and several of us attended, which was about the development of robotic systems across the NCA, which had a mix of orthopaedic colleagues and surgical colleagues from across the NCA, and they were talking about the enhancement of the robotic proposition across the NCA. And when that session concluded, at least 3 of those colleagues, certainly in the conversation I heard and had with me, said that they felt that the clinical leadership model would open further opportunities for that type of work going. So I guess what I'm just putting into the room is, whilst there might be a perspective that says, have we got clarity, certainly through Julie and some of the work that's been done and the communication in our organisation, people are starting to form views. Are they fully formed, and would they align with ours? Legitimate questions. But I wouldn't want Joe's input to kind of read out as if there's a whole lot of people out there who haven't started to build some thoughts about this, even if it's anxiety. And I think that's actually quite a good thing. So I've just put it into the room, a perspective. And if part of it is, well, we need to get really, really clear about what our thoughts are, I accept that. But one of the reasons we created the design groups as well is to make sure we don't fall foul of us just directing them with what we want to happen. So there's just a few things I just want to put into this conversation before we all say, well, actually, we adopt Joe's position and therefore we have to react to Joe's position.
Nothing you said contradicted what I said. Everything you said just complements what I said.
Michael. If you like.
So I feel like you're contradicting what I said, but you're not. Everything you've said and what I said go together like that.
Yeah.
Everything.
So I would agree. The important thing is with the responses that Joe said, it gives the opportunity for us to triangulate. We're all hearing different things outside of this room. So there are 2 emphasis points. One is having clarity and checking our own understanding. And the second point was that we want to hear about what you feel you can evidence, and we want you also to hear what you feel we have heard. And so just bringing that all together. So I think we are on the same page here, which is why I feel that the 3 R's probably appropriate, but it's not.
Yeah, I'm not sure.
What you're saying.
I'm not feel we are all on the same page. So
I would just clarify what I didn't. I meant if I implied people are not finding out about it, that would be absolutely wrong. I don't think I said that. But all I was saying was there are various layers, and they're rippling out a little bit. People and their key and their direct question to the programme team is, where are the execs on? Where are the board on this? And really, it was limited to that. So I know because of Julie's work, because of the work of the design groups, that the knowledge of it, and the more people know, the more really they're then saying, and the chairs had explicitly asked to meet, certainly with execs, but I thought board was a better idea personally. But again, that's just one. Always happy to be one point of view. So that was the real concern, whether you're content with the sponsorship and ownership that you feel you have of it, and whether then connecting with the design groups in that way helps. And so really that was all I wanted to. Thanks.
So what we'll do is we'll pick that up again and discuss it further, just to do that we did make sure we are repeating them when we have things.
Thank you, Chair. So this is a big change for the organisation. It is a very complex change, and I think as we've gone through the journey, part of the delay has been us realising, if you like, the layers of complexity that exist. It doesn't surprise me that there is nervousness in the organisation, whether it's amongst us as a board, the staff centres, exec colleagues, or in the wider organisation. None of that surprising me. I think there's a couple of things worth extracting from that. One of them is a sense which, as exec colleagues, we've discussed of possible uneasiness or as executive functions, it is difficult for us to relinquish the responsibility of aspects of that. So I think that's been uncomfortable for us. I think it's a positive thing that we're doing this, and I think we should continue and maintain with that. But there are features of what's happening that I think reflect that unease. We need to be conscious. CLM is definitely becoming part of the language of the organisation. I hear it. It pleases me when I hear it from people. It surprises me sometimes. Maybe the way it's framed isn't always 100% accurate, but it's definitely out there in the consciousness and part of what people are expecting and what people are formulating opinions on, including a degree of resistance to some of it because some people are comfortable with the status quo, and that's something we should all expect. I think part of this discussion is a reflection of the fact that that environment, if you like, is creating some difficulty for the design groups, and especially I think the chairs of the design, because we've tasked them with something that they, I think, are a little bit daunted by. We've said go up and come back with a design, and even though we have all of these safeguards, they're feeling and they have explicitly said this, they feel the weight of that responsibility. And so I think where maybe we are faltering a little bit, going back to what Aziz was saying, and I'm very supportive of that, is the noise or the sensation that there may be wobbles in the leadership of the organisation around this is causing them their own anxiety, because they're now hitting, I'm doing this big thing, I'm having pressure from here and there, and we're telling them, you shouldn't be unduly influenced by any external colleagues, etc. But then they feel like they're not sure that they 100% have our backing. So that's something we absolutely need to resolve. Part of that, I think, is also a manifestation of the fact that we've intentionally made them independent and taken a step back. So I think they feel a little bit exposed. And my reflection on this over the past couple of days, having had some conversations, is the need for me as SRO to be more present with them in a way that doesn't influence them in a particular way, but supporting them. So that's something that we need to do. And the final thing for me to say is absolutely supportive of ensuring that we have right mechanisms for the collective board to be close to this and are informed so that we all feel like we are speaking with one voice. It doesn't mean that we can't have disagreements or anxieties about where we are as a programme, but I think we have a responsibility in terms of how we reflect that out and ensuring that those are more internal discussions rather than being things that seep out. Thank you.
Thank you very much. Your points were really well made. I think there is something there for us to pause a little bit and reflect upon, and that is that this is a change programme. It's going to land differently and be heard differently and be responded differently to the person's circumstances and where they are within their own life or within where they are professionally. So I'm mindful of that, and so absolutely we need to make sure that we provide adequate and appropriate and relevant support when it is required and is needed. So we take that all of those areas you have just said very clearly been described to us, in addition to what Joe's been saying, what Owen's saying, and we must make sure that particularly the support is visible and accessible in the way that you described. So thank you, Rafiq.
Thank you.
Myriad, please.
So I think some of the things I'm going to say have probably already been said, and I agree with what you said. It's complex, it's critical, important, and I think that articulates why we are talking about it. And I think for me it's positive because it means we want to actually own it, we want to support the addicts and help important it is. But I think the bit, if I go back to the last statement you made, is maybe the mechanism for how we stay close communities probably the gap. Before we had the session on 4th of September, we had the same discussion that said we've been giving feedback and we're not very clear what's happening, what's going on. We had a session on the 4th of September, and that was really good because I think we started to paint the picture of what's going on. And I personally walked away understanding what was going on, what are the benefits we want to articulate, and who is involved and what the negatives were. But I don't think we agreed then the mechanism of how we do the drumbeat on those to make sure that we paint the full picture. And I think maybe that's what we put in place that says, you know, the same we've done with FSP. We came in at the beginning of the year with a big challenge. We put in regular touch points to say every month we will have a dedicated time to think about it. And I think that's got us to a much better place. So maybe that's something that we need to do that says, what's our mechanism of connection that's regular, that's because it feels like at the board meeting we asked, can we have it, can we not? But I think if we try and structure that, I feel that would help. The one thing that we came away with, and I look at my notes, was we could understand that there were benefits, but we couldn't really put them in a tangible way to call it. You know, when we talk about economies of scale, if I'm sitting on the line, is that translating for me back to a point Joe made about being relatable? And it wasn't for us, and I'm sure that is probably the same thing. So I think there's a bit of, we all understand these pieces of a picture we need to paint, but the mechanism for making sure that we put that together is probably for me the gap. And I think if we can find a way to put that in place, maybe that would help us connect with the teams on a more structured, more regular basis, and also paint our own picture and understand, remove the noise, because we start to say the same things.
Thank you. Points are really well made and resonates with all of us. So there's something that is relatable. The conversation and the focus of having that the support, but also the meetings and at the right time to have some more kind of to bring that consolidation. Can I?
And if I push it forward, maybe mine is, can we take a tangible action to actually put that in place?
Yes, we are going to. Yeah. It was that. Well, I think it was an action that I'm literally right at the beginning. Yeah, it would do.
And then put in the diaries and
Thank you so much. Again, I didn't make it earlier. Thank you, Maria. So, Jeff, please.
Thank you. My comments were about the action we're taking on this. So, this is a big change programme. We're in that market ground, aren't we, between the old model and the new model, and therefore you are bound to get these models. We ought to, as a board, I think, make sure that the design team who have been tasked with doing this, as it says, are supported by us, not undermined. There'll be enough problems out there without us adding to their problems. And as I heard Joe's input before, it was actually about us. Are we, as a board, sector non-execs, aligned with this? Are we relating to it? And I'm not sure we are yet. That's nobody's fault, but that's how I feel about it. I hear Owen saying that if you go around the organisation, not everybody's happy, but people understand it now and engage in it. It's good. We've got a clinical director in the care hall saying, how select a place? I'm glad he or she's asking that, but so am I. That's one of my fundamental questions I'm still not clear about. So we're going to sort of help here. We've got two suggestions. No suggestion that we as a board meet with people doing the work. I think that's the chairs of the design groups. But also Rachel said before that, well, before we have a meeting, can we get some answers to the issues that were raised at the workshop? But I think that would help us. I don't want to go to a meeting with the design group chairs and those raise all these big points of principle and they go, we're doing the work here. Now you're undermining us by asking these points of fundamental principle. So maybe there's the way forward is to, yes, have the meeting before the meeting is held, just have a write-up of that workshop and try and get some clarity amongst ourselves about what those big issues are, and not to answer them, but to get to a point where we can agree what those issues are, and if necessarily park them, having enough assurance they will get dealt with at some point in the process before it's down with the chairs of the design group.
Yeah, all of those points are very well made, and I think we've got questions of where we need to, what we need to do first before we have the meeting, which is what I'm saying, should be shaped. Should shape the agenda we then have with them. Thank you, Jeff. And I'm going to go back to Rachel. Rachel.
Thank you. Support Miriat and Jeff's point, so I won't labour those. One other point that you raised, Rafiq, there was the point around CLM being conceptual. I can really relate to this in some of my other roles outside of the NCA. And actually getting that robust case for change is key. Sometimes can still feel conceptual. Whereas actually one powerful tool I think we could consider, which I did raise with Peter and Alistair, is looking at bringing some case studies from other organisations where this has added value, and bringing some stories from, clinical colleagues, colleagues across that care org to come and say why it made their life easier and why it made patient care better, for example. So that's definitely something I've raised with the programme team that can help with some of that. It's a conceptual change. It's not going to actually benefit me. Thanks, Robina.
Thank you. Chris, please.
People have made the points I was going to make, particularly Jeff's points.
What?
Particularly the points Jeff made.
Oh, you were going to say some other things. Right, thank you very much. Okay. So colleagues, we've created lots of actions, which I hope Jan has noted. I'm sure she has done. So I'm not going to labour on them. So I think it was a really important discussion. Thank you for your candidness in how we unpack this together. And I look forward to having further conversations to achieve the assurance that we desire and we seek, to have the clarity of this shape and what we're just understand at board level or what is understood outside the organisation. And finally, that we provide the right support mechanisms for the team who are working on our map and delivering into the programmes. It is that around connectedness, need to be relatable, and we also, I just feel, will be in a better place once we've had that next conversation, which had to be informed by, first of all, responses to the original questions asked. From following on from that update we had with Alistair. Thank you very much. Can we accept the recommendations under that item? Thank you.
Could I just check, Chairman, has that concluded 13.2? Sort of check.
Yeah.
Sorry, just check.
Thank you. Okay, so agenda item 14, recommendation and deciding that report.
Thank you, Chair. The context the board will be familiar with. This is our latest AAA report from our last green recommendations oversight group. And despite some of the detailed discussions that we've had, the bits that I will just highlight and then take questions is we are spending some time ensuring that we capture all the concerns from different colleagues across our final service at different stages in one sort of consolidated list that we can actually work with, and we're channeling that list to the appropriate owners of governance within the organisation. And that includes also feeding it into aspects of what's happening considering, for example, the governance arrangements for the implementation of CLM, which we've just discussed. In our last meeting, there were a couple of things that emerged as issues that we needed to intervene to resolve, including MDTs from a spinal perspective, which we were working on resolving, and some other issues related to which I referenced in the learning from that report, are some of the variants in what entity arrangements. So that's in hand. The reviews for the 36 patients that were identified post the publication of the two reports, patient safety look back and the green report have started in earnest. We had two, external reviewers who were working through those. We anticipate that we will be able to meet the 6-month timelines that we had proposed would be required for this. I had originally been a little bit concerned that we might need to slip that the rate that we're going at now. I have much more confidence that we will meet that deadline. We have another upcoming meeting soon where we will be discussing a little bit more depth some of the governance requirements and data mix changes, etc., and just absorbing some of those changes that Heather and her team are very kindly sort of working on. I think one of the things that is a bit of a challenge for us in the green oversight group that we need to ensure sort of demarcating is the fact that a lot of the work that we are inputting into will tend to be subsets of a wider piece that is already happening in the organisation. And so we just need to make sure that we are articulating that very clearly, which bits we are actually looking at under that, and what mechanism we're going to use to actually close down all of those actions as we move forward. And there's a learning point, I think, for us that was discussed at length related to ensuring that we are communicating with our patient group and wider stakeholders, regardless of whether or not there were significant updates or shifts, so that people aren't filling in the gaps. I'll pause there and take questions.
Thank you. Are there any comments or questions? It's a very thorough and comprehensive so thank you.
Thank you.
And I do want to just emphasise the patient communication, which is absolutely essential because this is why they're doing things, not just for our colleagues but also for our patient.
Noted.
Yes, thank you very much. So can we note the recommendation that we have accepted the report?
Great.
Thank you. Agenda item 15, report from the audit committee. Tim?
Okay, thanks, Chair. This relates to the meeting 17th of October. There are a couple of recommendations actually with this AAA report, so I'll concentrate on those. I mean, the audit committee itself does have a responsibility for forming a view on the integrity of the overall risk management arrangements. So the committee discussed this and wanted to put a bit more kind of detail about how that is done. And it was felt helpful to sort of exercise that responsibility through the risk management group not reporting in a formal sense, but coming as part of our work plan twice a year to enable the audit committee and the non-executives to form a view on to get assurance on the integrity of the risk management arrangements, not to manage risk in any sense, but to get that independent challenge and view. And in doing that, probably to have an audit and risk committee title is also a helpful signpost. Certainly regulators, this wouldn't be the principal reason, do ask how do the non-executives form a view on risk and are cited on it. And this would be a kind of helpful tidying up of that responsibility. Second one was around clinical audit. This was a bit of a duplication that same reports were coming to the audit committee and to quality and performance on clinical audit. So it's been a meeting with Rafiq and Jane just to simplify that. And the quality and performance committee is the place where oversight of the clinical audit plan, its delivery, its resourcing is looked at. And the audit committee would only look at clinical audit from time to time, as with any other function of the NCA. The only other areas, see the annual report and accounts, which we've seen at the Council of Governors meeting, came through the audit committee along with the external auditor annual report. Positives around the closing of all the actions around the PwC review of NCA governance. The deep dive that Craig referred to and supported by Louise was very helpful with regard to putting spotlight through that process on capital investment. And just a quick mention on the overdue internal audit management actions that had been a bit of a backlog in the last 12 months. A lot of work has been done, and thanks to exec colleagues for leading that on closing those. So those are the sort of main issues, but there are those two issues around sharpening up the risk responsibility of the audit committee.
Thank you very much, Tim. Are there any comments or questions, particularly around this, the strengthening and the revision of the title in terms of purpose and role responsibilities extending to risk? Okay, that means I feel, Tim, that we're going to accept all the recommendations that you planted here, which is good and positive and the right thing to do. I'm saying that.
Yeah, great.
Thank you very much. Right then, we move to agenda item 16, integrated performance scorecard. Jude.
Yes, so I think we've probably touched on a number of the metrics in the conversation that we've had today. Just a question for non-executives is if there's anything else in the clinical safety and quality indicators that you think that we haven't touched on, then to raise that. I think we need to be really cited on those people metrics, and particularly the sickness absence. Without our people, then the quality, the performance and the money are all impacted as a result of that. So, you know, there is a risk, I think, as Heather articulated, to the bad spend, but particularly as we get into the winter period, you know, we continue to encourage our staff to be vaccinated as part of our winter checklist. But, you know, we're heading into a winter period with higher than sickness absence levels than ideally we would want to have. So I think we just need to be mindful of that, because without our people, they are our capacity at the end of the day to deliver across all of our plans. A couple of things just to say on the operational performance. So whilst we didn't hit the absolute zero number on our elective recovery for 65-week waiters, we were commended by NHS England on the number that we did manage to achieve, which was 119. They told us that benchmarked incredibly well with organisations of our size, you know, who probably started this with much bigger backlogs than we had. And also we were the organisation nationally who had removed the most amount of, or reduced the 52-week waiters by the most amount in the country, and the second largest reduction of 65-week waiters. So that's not to say our absolute number in those two categories is not big, but actually the biggest, you know, some of the biggest reductions that they had seen across all the key providers. So, you know, a big well done, I want to say, to our teams out there, and that's not just our clinical teams, but it is our administrative teams as well, who are validating that waiting list. You know, because we do remove people from the waiting list other than for treatment. So a big thank you to me for all of our teams in delivering that. We'll continue to focus on it. I think nationally that 65-week wait of zero was missed across quite a number of organisations across the country. So I think the ask of NHS is zero by Christmas time. And this month we are hoping to get that number down to 90, around 90. We've still got some validation for the month of October to be done, but we think we'll land October around the 90 mark. So we're pushing really hard. We've been going into November with a sort of risk of about 48 patients that we're worried about, and they sit across dermatology and gynae, and some of both of those are about capacity in those two services. But teams continue to focus on that. I think on the urgent care space, what I would say is we are static in our ability to deliver the 4-hour standard. If I start with some positive news, if you look in the GIRFT data, and particularly the SEDIC data, the summary indicated tables from GIRFT, our performance on frailty across some of our organisations is really good. And I think that is in part due to the work that we've done on days kept away from home, the work that we've done on same-day emergency care and frailty. If you remember, our original triple strategy was more SDEC, more short-stay frailty. And you can see that original strategy has delivered some real improvements. So Bury being one of the top performing hospitals in the country, the top performance from the country for frailty with less than 3 days active stay. So I will bring to quality committee a flavour of some of that data, because below 4 hours is some good indicators that we are moving in the right direction.
However, we have to translate it to a 4-hour performance and getting people in and out of the emergency department. We've mobilised some additional support thanks to Craig and the finance team. We've got a bid into NHS, so we will convert the income for that. But given the timeliness and where we are with winter, upon us, mobilise some additional support into our emergency departments. That's not to say that our emergency departments are part of the problem in urgent care, but it's to mobilise that. Actually, are we huddling? Are we escalating? Do we really kind of understand what more we could do within the department for the non-admitted cohort of patients? We know that flow into our hospital beds remains challenging, but we still have patients that reach who will never hit a bed. So are we directing them to same-day emergency care in a timely way? We recognise that their treatment cannot be completed in that 4-hour standard. And do we understand that over the 24-hour period, we know that the out of hours is a considerable barrier, I think, to decision making, and that's about the level of senior decision makers and the number of staff that we have available, medical staff in that out of hours. So that's a bit of work that we're taking. Chris, I feel like Mrs. Sloman, or are you being served? Yeah, waiting for old Mr. Grace to come through the door. So we've got work that is ongoing. We've got additional improvement support that we are mobilising through our emergency department. We are going to have a conversation today about continuous flow, and Heather and I are working really closely together to ensure that we have got mitigation plans in place that doesn't risk shift back into the emergency department and create additional impact on 4-hour standards and risk in that space. So we can talk about that later today. And the other positive thing that has happened this month is the launch of the internal professional standards that you might have seen in some of the trust communication. We launched it in Pradeep's absence at the Chief Medical Officer, but we did a pretty good job, I think, of being him in that space. So, there is work for us to do both executively, collectively, to support the thing, but a lot of that is about, messages to our medical colleagues about the responsiveness they're needing, and that's as much about cultural change as anything else. So if we think about where the 4-hour breaches happen, there's a volume that sits in medicine, in medical specialties. There is a longer length of stay. The longest length of stay are in mental health, and that's work that I'm going to pick up in our POM meetings because they do have the longest stays in our ED. And then I think there are just some ownership issues, cultural issues, responsiveness issues that probably sit with our surgical specialties. And so I think we just need to think about our actions in each of those spaces, I think, and where internal professional standards can help us in. The only other thing I want to pull out is about cancer. So I think I had reported at Quality and Performance Committee that informal conversations, so we've not yet, Owen and I, had a formal letter on this, but informal conversations we may enter tier 1 for cancer, and I think that's absolutely right. It was done in conversation with us as an organisation, and certainly we have found being in tier 1 for elective recovery actually quite supportive. It's helped us to deliver some improvements. It's likely we might move out to tier 1 for elective recovery, which would be good news. But moving into tier 1 for cancer will give us access to some regional funds to support recovery that we don't have access to from GM Cancer. GM Cancer have been enormously supportive of us in our cancer recovery space. So again, we'd like to place that on record. And they've been enormously supportive with cancer recovery funds, particularly. Craig and I have not yet
locked down a settlement on dermatology with the ICB as a result of the Tameside closure. We've really been, I guess, propped up in that recovery by GM cancer and hopefully by this sort of new bond that we can access. So we have put in a bid of 750,000 to help us. We haven't heard anything as of this week about whether that's been accepted or not. It sits across 3 areas of cancer. So one is the biggest part of it is dermatology. There is a little bit for lower GIs to deliver some additional sessions, in particular for EMR. And then the other area is urology, which is the delivery of some additional sessions. We're over the summer, that summer peak that we see. So we're at the back end of some of that demand starting to settle. We know that along with Tameside, that primary care demand, back to Jeff's points earlier, I think, when we have that demand strategy conversation, did overwhelm and implement all the really good improvements that we put in place in dermatology to create that capacity. So we continue to focus. We went live with skin analytics last week, so that again gives us some additional capacity, helps us with the FDS standard, and nationally they have supported that consultant secondary in that as part of the safety netting for the AI technology. So I'm going to pause there. We've got a bigger conversation at board strategy in December on dermatology and where we are, because it's a big driver of both elective and cancer performance. But we have got some significant ambitions. The final thing, actually, I did forget this, is to say what I had reported at Quality and Performance Committee is the ICB had served notice as it steps into its redesign of dermatology across GM. It had served notice on the community providers as it retenders and awards new tenders. There were risks associated with that we drew to the attention of the ICB, not least because HCRG, who provide both community and secondary care dermatology for the Oldham population, see cancer patients, so they see 2-week wait referrals, and they see just shy of 2,500 2-week wait referrals. And so in serving notice, the new community tender does not have 2-week wait cancer referrals as part of the specification. So there was a risk that all of that lands back with us. So we've had some discussions with the ICB, and they are going to do a contract adjustment to mitigate that risk.
Thank you very much. It was comprehensive and very helpful. Can I begin by just saying on behalf of the board to you and your team for the remarkable position you placed us in regarding recognition from NHS England. That's a very difficult position to achieve. That doesn't come unless we've been noticed, and that comes back right back to the hard work, but with your leadership and also that supports you. And it's very important that we as a board recognise that, because notwithstanding all the challenges that we're facing and regarding meeting our waiting time, the fact that we've managed to make that kind of reduction is very significant. So thank you. And I'm mindful of the point you made earlier around if we don't have our people, then we can't deliver our service. So the sickness absence is a really critical risk that we just need to make sure we put in interventions, as I described. I know that goes with this area, but our focus has to be on that capacity and capability piece. Because whilst we have all of these standards and we seek to perform, we put everything in place, without our people, we can't. And winter is definitely. So thank you. I will come to question disease. You had your. Oh, here. 6. Okay, so no questions, I think. Right. Thank you very much. You have that comprehensive team. So can we accept then recommendations under agenda item 16, please? I suppose so. Thank you very much. Board assurance framework and corporate risk register. Jane.
Thank you very much. It is as presented, Chair, in the board. This is the quarterly update of board assurance framework, coming again to the board in January, reflecting 42's position as updated through our board committees and by responsible executive directors for each of the risk roles. Papers presented on behalf of board committees and execs, as I say. Ravina, I think the paper is clear as presented. I'm happy to take any questions. I'm sure the executive colleagues are also.
Thank you very much. Are there any questions? Yes, we have a couple coming through. Maria, please.
And I don't know, James said it's literally not getting any question, but we had a conversation earlier about capital investment, knowing that some of it is not going to come through.
Sorry, Mary, I'm not hearing you properly. I do apologise.
Sorry. I don't know whether it's a timing question because he said this is Q2, but we had a conversation earlier about capital investment, and I think he said there was 26 million that won't come through. I just wondered whether that's been reflected in here. Okay, fine, but if it's a question for Craig.
Just
Yes, please.
yeah, we've done a recent audit committee review. This risk will capture not only the size of the capital plan, but other attributable risks like RAC that we've described, and there's some listed there about the positions of capital within the care organisations. We did talk about the need to recalibrate with the news of the Penn transaction. However, I don't think it materially impacts the risk, because we were working to a reduced plan internally all along. We have to understand that even though at the outset we were asking for the 26 million, we knew that there was significant risk at the beginning of the year with that, which was highlighted in this report. So I think we need to work on the narrative of pulling that out more clearly, Miriam, because it's not entirely clear when you look at that through the narrative that that's the case. But I'm not anticipating a huge shift in that as a result of the news on NHS transaction.
Thank you. Thank you. Chris, please.
Jane, I was just trying to relate the earlier discussion on annual objectives plan, see where they connected. Because I think the answer to the question, how does the board look at the objectives and plan? I thought it was the back.
Yeah.
Is that, am I in the right? Is that the thinking? Because at the moment we seem to have two sets of annual objectives or plans that people are looking to. Do they overlap?
If I may, please. They absolutely overlap. Absolutely overlap. The BAF reflects those risks and our action plans to mitigate those risks.
Yes.
Thus delivering on our annual
Really,
objective.
the BAF and that earlier paper together, it gives you a more comprehensive sense of where we are.
To put them side by side. Absolutely, and I think as we do that, that's some learning for us, Chris.
Thank you.
Wait one minute, thank you, Chris. Lorna, please.
I'm just reflecting again on the conversations and the topics we've brought through the board, and I'm just revisiting the quality standard BAF risk that we've got, which we're scoring at a 15, and I'm just then reflecting the conversation we've had about gynae, the conversation we've had about maternity, the conversation we've had about CQC, and I wonder whether that is maybe just slightly too low right now, and whether we need to reflect that. If I look at across some of the other ones, the scoring change portfolio higher, scoring change of leadership as a higher risk than our quality, and I'm not sure whether that's right or not. I'm not sure I've got an answer, but I'm just reflecting on the topic and the conversations we've again spoken today about.
And it's a good reflection, because I think that's exactly the pause we need. does the risk that we apply to for insurance purposes, is it correct at the time of printing? Yes, it is, but will it change? Yes, it will, because sometimes we go off track and sometimes things happen which were unplanned and unpredictable. And so it is a fluid number. Quite right, we need to go back and just revisit it on the basis, certainly of today's conversation. Rachel, please.
My question's been answered. Thank you, Rabina. Thank you.
Thank you, Chair, and I might ask Aziz to assist me with this. I know that Bathurst 3 and 4 are showing as having been reduced, and I apologise, colleagues, as it's my first time seeing this report, so if I misread it, help me. But due to the late circulation of those risks and the associated paper, we actually didn't have the opportunity to consider it at People and Education Committee. Therefore, it's a point of accuracy for the board that those scores should remain as 12 and 16, and we have agreed to review them, if I'm correct in setting this out, Aziz, at this month's People and Insurance Committee. So they have not been reduced, and I think it's important we make the board aware of that, as we've not had an opportunity to discuss that. Which I think I'm getting a nod and nod my colleagues, so we're to note that they have not formally changed.
Thank you. Thank you, Chair.
Thank you. That's again, it's really important that we do review, don't take for granted, or it's not a given. That's why it comes to people. Thank you very much. Chris, are you coming back in?
No, I'm just.
It's like your little girl here.
He's making noise.
Have you done a header? Yes, it's just a continuation of what you said, Ravina, but with regards to the VAT risk around maternity, just to give the board some assurance that, I don't know if people agree with this, but people might have a sense that maternity is going in the right direction, and there's a mismatch between the current staff reporting and what it feels like. I did have a discussion with Lisa. We went through thoroughly. The actions are productive and effective. We are seeing improvements, but we wanted to wait until today's assessment to help us with a definitive reassessment. So I think it's ditto to what was said earlier. It will be changed, but we are waiting for some objective clear line assurance.
Thank you very much for that. So, are there any comments? I have none. Can we move to the support recommendation that was making Jane and team for putting the paper together for no need task? Okay, agenda item 18, which is the register of the sealed documents. Jane?
And that's for information only, Chairman.
Right, so again, recommendation noted, colleagues? Not here, Jeff, for you. On behalf of everybody, Jeff. Chairman's report from the Governor presented for information and related to the meeting held on the 15th of October. At 5, we move then to agenda item 20. The Board of Directors closed session for information for meetings held in private on the 2nd of October. This paper is also for information only and is provided in the spirit of openness and transparency in public domain. Board performance and reflection. The biscuits were really nice. As detailed there, are there any comments or?
The 4 minutes over which counts as on time.
Is there any other business?
Sorry,
yes.
I've got a comment which might blow that out of water. No, it's not going to. It's a point of clarification with regards to an earlier discussion around the information system. I used the term curing. I think I want to replace that with exploring. And confirm with the board that we are not in any procurement activity. I just wanted to just clarify that.
Yeah, that's an important clarification, isn't it? So thank you for that. Which is enhancing all of the risk associated with that item. Things above the lens. Thank you very much. Date and time of next meeting, Wednesday, the 8th of January, 2025 at 9:30. Agenda item number 4, to the resolution to exclude the present public from the meetings at this point on the grounds that public publicity of the meetings have been reviewed would be prejudicial to public interest by reason of the confidential nature of the present public are requested to leave at this point. Can I thank all my colleagues for a very constructive discussion and thank those online for attending. That concludes the agenda.